Okay, so just to give you a quick summary of what we plan on covering today, we are going from the basics to start with what imaging markers you're looking for when you want to call something confidently as infection, whether that's on CT or X-ray. Uh, and I will then discuss whether there are specific appearances of various types of infections and can imaging always differentiate them. Um, the second part of the session will be focused around a focal lung lesion and what it means to call something a nodule within the lung. And I really want to drive home the message that every dot, every lesion in the lung is not a lung nodule, and what it means when you actually label something as a lung nodule. And once you have done so, what you need to do on your initial assessment of the nodule and what you need to recommend. And this is obviously based around the UK guidelines. Depending on where you are in the world, you may have your own national guidelines. If you are in America, you may follow the Fleschner guidelines, but within the UK, the BTS nodule guidelines supersede the Fleschner guidelines. And obviously, if you're studying for the FRCR examination, these are the nodule guidelines you need to know. You may not need to use them for follow-up if you're not a dedicated thoracic radiologist, but depending on what kind of center you work in. If it's a general, smaller DGH sort of setup, then you may need to be, um, the jack of all trades, and you may need to recommend nodule follow-ups and need to know when to escalate a nodule as suspicious for cancer. Talking about lung cancer, one of the biggest cancers in terms of morbidity and mortality across the world. UK is no different. I want to talk about lung cancer imaging, what you look out for when there is suspicion for underlying cancer, what you look for when you are labeling something as possible cancer, how you need to describe it, and what you need to recommend. Because the message uh, with clinical radiology is you're not just describing something, you have the knowledge to recommend next steps, and that is what is expected of an FRCR or a clinical radiologist. So when we talk about infection or when we say infection, this is the barn door appearance when we think of a very clean looking, isolated lobar sort of consolidation with very clear air bronchogams through it. But obviously real life doesn't look like this. When you talk about, when you think of an image that would make you very happy calling it, labeling it as infection, the history states the patient came in with a fever and a cough, and this is what the X-ray looks like. Obviously, it's much easier to report that X-ray. There is nothing suspicious within that opacification. There is no more dense sort of opacity medially. There is no associated bone destruction. There is no pleural thickening. So this is what you would expect in a very run-of-the-mill lobar pneumonia. But obviously, the very few organisms give us that presentation in real life. And the more, the sort of organisms that give us a lobar or isolated pneumonia is streptococcal, Klebsiella, staph, TB, not so much these days, as well as strep. When we go back to that appearance, sometimes you can see that this fissure is actually straight or it's bulging downwards. And what that means is that that consolidation is not as simple as you would expect it to be. So when you get consolidation, you inevitably get some collapse around it or distal to it, and that gives you a bit of volume loss. That's why most people report consolidation as collapse consolidation, because you can see some sort of volume loss in that area of the lung, and that's what this upward curvature of the fissure is telling you. But when that fissure is straightened up, or when very rarely it's bulging downwards, it tells you that there is mass effect or there is actually expansion of that lung tissue. And the only way that can happen is when the air spaces have filled up so much that they're actually bigger than they would be if they were filled with air. So this is a very common exam question as well, that which kind of pneumonia would actually give you increased lung volume that would give you a mass effect, a sort of imaging pattern. And the answer is any infection with a abundant exudate. But if you give that answer in an exam, you're often pushed for which organisms do you know of that give that appearance, and the answer they're looking for is Klebsiella. So Klebsiella is the organism most commonly associated with lobar pneumonia that can give you that sort of bulging of the fissures. Obviously, when that consolidation gets complicated with development of isolated lung abscess, that alone has mass effect. So the abscess is a space that is getting filled up with pus within the lung. So that also will give you enlargement of the lung volume. So that also gives you bulging of the fissures. But obviously, um, last on the list, but obviously the most sinister one is lung cancer. So lung cancer then gives you bulging of the fissure, gives you mass effect, and that is the most important differential for any infection. Is this actually all cancer? Is there underlying cancer? Is there cancer proximal in the airways that is causing distal obstruction? These are the three things you always need to have at the back of your mind. Coming back to infections, chest X-ray, the most commonly requested imaging technique anywhere in the world, and the most common indication for that is consolidation. Most ED departments I request a chest X-ray on any patient that walks in. So the things to look for on a chest X-ray when the clinical suspicion is infection is very different when you have a clinical history versus when you don't. And the appearance are also, it isn't helped by the fact that the appearances can be very variable depending on which organism is actually causing that infection. So the appearances are as variable as the number of pathogens that are out there. When the question is infection and you have a chest X-ray in front of you, like I said in my previous session, your best friend is always the previous film. So if you have a previous film to compare to, reporting of any chest X-ray becomes immensely simpler than it would be if you had nothing previous to compare to. Obviously, history for consolidation or airspace opacification is almost as or probably more important than the previous film. When you have something abnormal on the chest X-ray, you then want to assess it if you're thinking of infection. So what I mean by assessing it is you're looking for air bronchograms because that's your go-to sign, and the most reassuring sign is when you see consolidation and you see air bronchograms through it, you know that the airways are patent through it. That means that the pathology in the airways is not aggressive enough to eat through the airways next to it. So that implies benign pathology because benign pathology will spill over, it can't eat through the airways. So that's why we look for air bronchograms. After you've looked for air bronchograms, you want to look for volume loss. So is there collapse associated with the consolidation? Is the collapse old? Is it new? Is the collapse causing anything? As in, is it causing shift of structures around it? And you also want to describe architectural distortion. If you remember from the first session, I mentioned what an important term architectural distortion is. It's almost a non-committal term, but it is explaining to the referring clinician that there is active process going around that consolidation or has gone on before. So in very severe or extensive consolidation, you can see architectural distortion almost immediately. What that means is the lung is trying to heal itself. And when it does so, it either does it successfully or unsuccessfully. Regardless, you develop architectural distortion. And that's where follow-up comes in. When you follow up architectural distortion or air space opacification, you would see one go down and the other go up. So as airspace opacification or consolidation goes down, the healing process goes up. So the healing process is often depicted by atelectasis or volume loss or distortion. When you have active consolidation on the X-ray and you have active concurrent architectural distortion, that implies a very significant infection or significant process going on because there is acute insult going on and the lung is trying to heal and it can't, and it's an active process. So that means that's either an acute presentation or a subacute presentation. Once you've described the opacity that you see, the other thing you always need to look at before you write off the appearance as infection is overlying rib involvement. This is extremely important in exams because that's a very typical film that examiners show candidates is when you have consolidation and you forget to assess the rib in front or the rib behind. And if you were to do so, you would see the subtle rib invasion, and that tells you that this was actually cancer. So because you can't always see air bronchograms on a chest X-ray, and you can't always see the typical round appearance that you want to see of cancer on a chest X-ray. So it's always important to look for ancillary signs that suggest that this is an aggressive or malignant process. So always look for aggressive features, always look for rib involvement, vertebral involvement around that opacity. The last thing I often tell the registrars is you're reporting the imaging, not the patient. Look at what you see and describe it. So, for example, if you see this chest X-ray that I showed you before, don't say right upper lobe infection. That's a wrong report. Your report should say right upper lobe consolidation, because looking at the patient, there is no way of telling that what that pathology is that sits inside the airspace. And what I mean by that is coming back to the anatomy of the lung. So if you remember from the first session, this is the airspace anatomy, basically. So this is the end airspace that fills up. This can fill up with many different substances, and when it fills up with exudate or pus or infective process inflammatory cells, that's called infective consolidation. But consolidation doesn't always mean infection, and that's the most important message I want you to take from this lesson today, is when you say consolidation, it doesn't imply infection. So when I mean report the imaging and not the patient, I'm saying report what you see on the film. So that gives the referrer the ability to think, and they can put the bloods and the patient in front of them and the imaging appearances and come to a diagnosis rather than go by your report of saying infection. Because what could just be likely as infection is that patient had actually hemoptysis and they had vasculitis that gave them that appearance. So did they have consolidation? Yes. Did they have infection? No. So coming to this slide is just to give you an idea of what kind of variation you can have. So this all of these pathologies on this slide can give you consolidation. So consolidation means filling up of the air spaces. When it fills up with water, it's heart failure, it's ARDS, it's low protein, it's renal failure. When it fills up with pus and inflammatory cells, it's pneumonia. When it fills up with blood, it can be trauma, it can be vasculitis. So, and this pattern is also as variable as the pathologies, and different pathologies can sit in different patterns. So one pathology can give you different, isolated lobar pneumonia can also be isolated, or pulmonary edema in heart failure, and just as well, diffuse multifocal opacities can be infection as well. So lobar pneumonia, very typically associated with the organism we just discussed. Also, lobar pneumonia can be actually all been cancer. Lobar looking consolidation can all be hemorrhagic. You can also have organizing pneumonia, sarcoidosis, sequestration. Sequestration, a rare diagnosis. Is it possible to diagnose it on chest X-ray? No, unless it's a very significant sized sequestration and you can see it on previous films and the patient happens to be asymptomatic. Diffuse or bilateral consolidation is a more systemic problem, so you have to think of either atypical infections, and what that means I'll come to later in the session. And what I mean by systemic is most common diagnosis that people think of is heart failure. So just to put that into some context, this is a film of a acutely unwell patient. You can tell that because there is a central line in, and I'll just open up the chat for 30 seconds just to see some differentials coming in, and then I'll tell you what this actually was. Okay, 30 seconds starting now. Okay, let's pause there. I'll go one by one. So I'll tell you why it isn't what you said. So batwing. Okay. I think one of you said that this is eosinophilic pneumonia, and eosinophilic pneumonia actually is a very textbook appearance. Is that the thing to remember with eosinophilic pneumonia is that it crosses fissures. it's like that process does not realize that there is a fissure going through. That appearance is very clearly appreciable on CTs, but on X-ray, what you would see is peripheral looking consolidation that goes through the lung, through fissures very beautifully. So that's a very textbook appearance of eosinophilic pneumonia. This could be, but it isn't. One of you had said COP. That's a good guess because it's peripheral looking consolidation on both sides. So it could be COP. The thing with COP is generally patients are not that unwell that they would end up in the ITU and they would have a central line. COP is more somebody presenting like a community acquired pneumonia again and again, and that's actually COP. They actually don't get that unwell that they end up as an inpatient. I think most of you said pulmonary edema. I think that's the most common um, finding. All of you would put this down as, but somebody had said subcutaneous emphysema and pneumothorax and consolidation. So in the context of subcutaneous emphysema, pneumothorax, and consolidation, you have to consider that this could be a hemorrhagic process. This is actually significant trauma. This is actually crush trauma on both sides, and this is really bizarre because you can't actually see the rib fractures. So it's very reasonable to call it as pulmonary edema or heart failure, but this is actually bilateral lung contusions and trauma. Again, this I'll open up the chat again, and this just goes hopefully to drive down the point that an appearance can be deceiving. So one, I want you to describe the abnormality a little bit if you can, but give me a difference or give me your top differential for this one. Okay, pausing there. Somebody said lung nodules, question mark, septic emboli. So when you want to say septic emboli, you want to see some cavitation. Somebody said heart failure or pulmonary edema. I've forgotten which one. But either way, I would really want you to look at the X-ray again. And when you want to call somebody as pulmonary edema, if you're saying cardiogenic pulmonary edema, you want pleural effusions, you want cardiomegaly, you want perihilar opacification. You see none of that on this chest X-ray. So heart failure would be pretty low down on my differential. Mixed nodular and airspace shadowing is absolutely right. You see areas that look like consolidation, but towards the mid zones, you see these nodular looking opacities bilaterally. So that's absolutely right. So the thing with this is very marked upper zone sparing, and that makes you think of rare and wonderful or very specific diagnosis. But having said that, um, I want you to really think that does it really fit into a pattern? It doesn't. And I'll come to the importance of follow-up because appearances can be deceiving. This is actually widespread metastatic disease. uh, I will talk about nodule follow-up in a lot of detail, and I assure you, you will understand it. That's lower down in the session, but I will repeat it. Don't worry, Wakar. So this one actually is metastatic disease. This is breast cancer. Okay, so this coming back to the next point that links in with the importance of follow-up is non-resolving or recurrent consolidation. Most of you already know the practice in follow-up. For those who don't or don't realize the importance of it, I hope you will learn the importance of it today. The issue with non-resolving and recurrent consolidation is you're trying to exclude underlying pathology causing that. The thing with non-resolving consolidation is that all of that consolidation can be cancer. The issue to remember with recurrent consolidation is we are saying, well, so obviously something resolved and then came back, it wasn't cancer. But we are saying that there may be something medially in the airways that is causing recurrent narrowing or obstruction of the bronchi to cause distal obstruction or infection. So both of these situations, you are suspicious or should be suspicious for underlying malignancy. And the issue with non-resolving consolidation is when we have a very textbook lobar looking pneumonia, we automatically think, oh, well, this is infection. Oh, well, I forgot to recommend a follow-up. What does it matter? If they were asymptomatic, means that it has resolved. The, the guidelines are, the recommendations are when you see something on a lung um, on CT that worries you symptomatically or radiologically, you should, and same for chest X-ray, you need to recommend a 6 to 8 weeks follow-up. What that means is the patient will come back and have a repeat of that same modality. When you see extensive changes like that, they can probably be followed up on a chest X-ray because you can probably see them on the scanogram of the CT. If they are small enough or behind the heart or in a place that you know you wouldn't be able to see on a chest X-ray, and the way to do that is to look at the scanogram. If you can't see them on the scanogram today, the likelihood of you being able to see them on a chest X-ray 6 weeks from now is extremely low. So there's no point of recommending an X-ray. You want to recommend follow-up 6 to 8 weeks to ensure resolution, whether you are sure or not sure that this is infection. What we want at the point of 6 to 8 weeks is complete resolution. When you have incomplete resolution, that is reassuring. And depending on what the specific appearances are at that time, you can either let it go, or if it's still a bit of airspace and a bit of nodular, fluffy looking appearance, you can recommend a further 6 to 8 weeks follow up. At the second follow up time, if you still see slow, subtle, incomplete resolution at the time of the second follow up, that again comes down to the appearance at that time. You can either let it go then, or if it worries you, you can recommend a CT. Most slow resolving consolidations have improved by the time of the second follow up or have improved enough for you to dismiss them. If you forgot to recommend a follow up and that patient came back in 6 to 8 months' time with a stage 4 tumor, you would be entirely responsible for not recommending follow up. And that is the importance of non resolving consolidation. And it is a very common situation with how advanced lung cancers present. Somebody labeled them as possible infection on X-ray or CT and forgot to recommend a follow-up. So some of the causes for non-resolving consolidations are inappropriate antibiotics, or more importantly, malignancy. And the recurrent consolidation is more inflammatory pathology, so that can either be organizing pneumonia, or it can be a flare of sarcoidosis, or it can be a flare of their underlying vasculitis. It can be somebody with an impaired immunity that has recurrent infections, um, or they can have underlying lung pathology that predisposes them, like emphysema, COPD, they're a smoker, low hygiene, and also recurrent aspirations. So non-resolving consolidation absolutely needs a CT if it's persistent. Recurrent consolidation, if the patient is asymptomatic, I wouldn't worry too much about it. But if the patient presents with an infection 4 times a year, either a respiratory physician or you would think down the line of, is there underlying pathology, and the ease of access to CT comes into play here, and most of the respiratory physicians for recurrent consolidation or recurrent pneumonic process would recommend CT at this point. There is no absolute cutoff, as in this many infections in a year or this many consolidation on imaging in a year to warrant. It's a clinical based decision. Suspected infection on imaging. For initial presentation, like I said, you do a 6 to 8 weeks follow-up. For recurrent infection, you do the normal follow-up, depending on whether you're reporting CT or chest X-ray as an inpatient or an outpatient. You may recommend further cross-sectional imaging. For non-resolving infection in commas or consolidation, you absolutely need to recommend cross-sectional imaging because that should be assumed as malignant unless proven otherwise. Recurrent consolidation can happen in the same space, and that happens when there is proximal isolated lung pathology like a bronchial stenosis or endobronchial nodule, benign nodule, but that makes that area of the lung prone to infection or the prone to poor drainage, let's say. The difference between recurrent consolidation and migratory consolidation is arbitrary. It's more a way of describing or implying certain differential diagnosis when we say migratory consolidation. The way to label somebody as migratory consolidation is more commonly on CT. The PAC system these days have access to decades of previous imaging. So migratory consolidation doesn't mean that the patient had a right lower lobe consolidation 10 years ago and today he has a left lower lobe consolidation. So that's a migratory consolidation. And no, we implying a pattern in the last few months that the patient presents with bilateral looking consolidatory pattern, but got better or resolved or improved and came back a few months later, still bilateral, but in different places. Or some of those previous patches got better, new ones came in another place, and some are getting bigger, some are getting smaller. This is called fluctuating consolidation or migratory consolidation. It's not the same migration consolidation moving from place to place. It's different time frames of different areas. They can happen in within the same um, space. For example, in this one, the right lower lobe wouldn't have resolved, and a new patch appeared, or more commonly, that improved or resolved, and the left lower lobe then appeared a few months later. And the differential for that top absolutely is organizing pneumonia. Organizing pneumonia can be idiopathic or what previously used to be called BOOP, so cryptogenic organizing pneumonia, or it can be organizing pneumonia because of a underlying cause. So if you look up causes or drug toxicities of patterns uh, of appearance that can look like organizing pneumonia, you would see pretty long differential. So you can have infections that look like organizing pneumonia. You can have drug toxicity that can look like organizing pneumonia. Um, Recurrent aspiration can look like migratory consolidation. Pulmonary eosinophilia can look like migratory consolidation, but this one, again, like I said before, it crosses fissures. So like here, this one, this one respects the fissure quite keenly. If this was a pulmonary eosinophilia, this would be crossing the fissure across it. Pulmonary hemorrhage, infarcts, vasculitis, they tend to cavitate or they tend to present very acutely in the sense the patient, if the patient presented with vasculitis and the lungs look like that, there is no way the patient would not be coughing up blood, and very rare alveolar proteinosis. Talking about the differential for organizing pneumonia, this slide I've put up because within the last 2 or 3 years, we've gotten very accustomed to this appearance, and most of you would recognize this as COVID. One of the patterns COVID presented was organizing pneumonia. So this again has peripheral looking consolidation, peribronchial looking consolidation. The pattern is organizing pneumonia, and this is caused by underlying COVID infection. Coming to atypical infection, what does atypical infection mean? So atypical infection is a term that was developed quite casually, and this was described to denote infections that behave differently to typical pneumonia. They either appear different on a chest X-ray, or they responded differently to antibiotics, or they um, were caused by rarer organisms. And these days, researchers usually consider bacteria as being atypical if they are either hard to detect or they don't respond to normal treatment. In terms of exam preparation or radiology, the most common atypical infection you will think about is mycobacterium infection. So mycobacterium includes TB, but doesn't mean only TB. Unfortunately, within the UK and many areas in the world, still quite a common diagnosis. The um, imaging pattern to look for when you want to call somebody TB is the question you will be asked is this active TB or old TB? And what you want to look for, and what you want to look for quite um, keenly, is tree and bud nodularity, because that implies active endobronchial infection, and that means that somebody is contagious or infectious. Bronchiectasis in TB can be chronic or it can be acute. Multilobar or bilateral involvement again can be chronic or acute. So it's the pattern It's the morphology of the lung changes rather than the distribution that implies active or chronic. One way of differentiating that is the patients are relatively well, but some patients are relatively well even when they have active TB, and what to do when you suspect TB on imaging. Of course, it's a public health concern, so it's reportable. When you have imaging that is very strongly suspicious of tuberculosis infection, the ask is that you have to notify the referrer. You have to know, depending on where you work, you can either have electronic notification, or you may need to fax or pick the phone up. Of course, when it comes to the pathologist or the histopathologist, when they have a definitive diagnosis, the responsibility sits with them a bit more emphatically, that they know that this is TB, whereas you are raising the possibility of TB. When you say TB, you talk about primary and post-primary or reactivation TB. Primary TB in the UK, they can present in older population, although rare. Those are almost all reactivation TB. And the scenario we are looking at in the UK is the immigrant population, or sometimes an overseas university student, young student, can present acutely with a very large pleural effusion in a 17, 18-year-old, is hemorrhagic on a tap, ends up being primary TB. It's not as uncommon as you would think. So primary TB, yes, pretty much still pretty prevalent in the UK as well, same as anywhere else in the world, I assume. Reactivation TB, more common in the older population. Is it always possible to tell primary TB from reactivation TB on imaging alone? And the answer obviously is no. You can only look for the points that point you towards one or the other, and you can make a reasonable decision or likelihood. Pleural effusion is obviously the more common presentation of primary. So if somebody presents solely with pleural disease or pleural effusion or pleural thickening, the likelihood of it being reactivation is lower than it being primary. Again, you have to look at the whole holistic pictures of the patient, the presentation, the age. Large pleural effusion with mild pleural thickening is primary TB. Pulmonary parenchymal disease is equally seen in both primary and secondary. The the region within the lung where you see them is slightly different in the two. Reactivation, obviously, you can read up in more detail, but the areas are slightly different. The appearance within the lung in terms of the endobronchial involvement, the bronchial wall thickening, the consolidation is somewhat similar. Lymphadenopathy, again, slightly more common in primary. Miliariopasties is a rare appearance of tuberculosis. It's when you see a miliary or almost diffuse micronodularity throughout the lungs. And in a young patient, very few other things cause that. Um, I will pause here and just to keep you on your toes, ask you if you know any differential of miliary metastasis, malignancies that can give you miliary metastasis on a chest X-ray. Okay, 30 seconds, starting now. Yes, absolutely correct. So those three are the ones you're looking for: renal, choriocarcinoma, thyroid. Prostate, not so much. Pancreas can be, again, not so much. The miliary pattern is very specific for tuberculosis in the right patient. If it's a slightly older patient, somebody who may have weight loss and known malignancy elsewhere, the differential becomes more important. But in a young patient, miliary changes whether the lungs are very suspicious for tuberculosis. Then you have the galaxy sign. You can see the galaxy sign in primary and reactivation TB. What is the galaxy sign? This is just a sign talking about the coalescence of the granulomas on imaging. You can see it on chest X-ray as well, but we don't really describe it like that on chest X-ray. We reserve this term for CT. And what you're talking about on CT is you can see diffuse and nodularity throughout the lungs, but when you see a collection of nodules tending to um, conglomerate in an area, or you can have a more dense looking, almost a nodular consolidation in the middle and smaller nodules around it, and almost looks like a galaxy of stars. And that is what was traditionally described as galaxy sign. It is not specific for tuberculosis. And when we say coalescence of nodules or suspicious of granulomas, that implies another disease as well. And that's quite common as well, and that's sarcoidosis. So not a specific sign for tuberculosis, but a very classical and historical sign. This chest X-ray is a young patient with bilateral changes. They are asymmetrical changes. There is no clear zonal distribution. You can see some areas that look like they may be cavitating. Then there are some areas that look like a fluffy nodularity, few tending towards consolidation towards the base. So if in a young patient, if you were thinking about typical infection or lobar pneumonia, this wouldn't really fit because the changes are bilateral, they're asymmetrical. If the patient is relatively well in the sense that they are not coughing up blood and they don't look like somebody who has septic emboli, they're not IV drug users, anything like that, then you see this bulkiness around the left hilum. You wonder, is there lymphadenopathy? So you have lymphadenopathy, bilateral lung changes, some of which are cavitating, and the cavitation is more in the upper zones. You have to bring in the differential for tuberculosis or mycobacterium infection at this point. CT for the same patient showing bilateral nodularity, tree and bud nodules, consolidation with associated cavitation in the left. So yeah, very suggestive of atypical infection, mycobacterium, in this case proven to be tuberculosis. If this was put towards you and somebody asked you, well, this patient has TB, we would like to know after 10 months of treatment, are they still infectious, or have they responded to treatment? The one thing you're looking for to rule out or rule in active infection is tree and bud nodularity. So if you see tree and bud nodularity on the CT today, you can't actively say that this is old TB. You have to point out that they may still be infectious, or they likely require ongoing treatment. Tuberculosis is just as common as non-tuberculosis tuberculous mycobacterium, and most of you know the term NTM infection. NTM infection is a term reserved for all the other mycobacterium that are not TB, and it's a very long list. Um, the most common of that we talk about is the Mycobacterium avium complex. It's a very typical appearance, let's say, on CT. And what I mean by that is, can you always tell that this is Mycobacterium? Yes, you can reasonably be confident that this is Mycobacterium infection, but you can't always be confident that this is Mycobacterium. This is NTM and not TB. So these patients almost always need endobronchial sampling to confirm one way or the other. NTM patients are usually generally well. They're chronically slightly unwell. They come to respiratory clinics. They have outpatient imaging, and a CT is usually much milder than the CT I've put up. So the most common distribution is they have a bit of bronchiectasis. It's more predominantly involving the middle lobe or the lingula. You have a bit of tree and bud nodularity. You have few nodules, some of which look like they're cavitating. So that's when you have to bring up the likelihood of NTM infection. When you say NTM infection, that patient, if they haven't already been referred to, needs a respiratory referral. They need endobronchial sampling for further management. Pleural disease isn't that much an issue with NTM infection as it is with TB. So if you see very prominent pleural thickening or pleural disease in somebody who looks like that, you have to think more along the lines of TB rather than NTM. Patchy consolidation can be equally common in both. Central lobular nodules, equally common in both. The distribution involving the middle lobe and lingula, quite specific for NTM rather than TB. So the three things to look for is pleura involved? No, tending towards NTM. Is upper lobe involved? Upper lobe, I mean quite high APCs. No. yes, start thinking about TB. Is cavitation involved? Start thinking cavitation, not in a small nodule, but in a larger consolidation area, in a predominant factor. And then you have to think around TB and not NTM. Is the middle lobe and lingula predominantly involved? That's a very big tick for NTM and not TB. Um, just aware of the fact we need to take a 5-minute break at 7 o'clock. But this is just to drive down a point that when you say consolidation, it implies the airspace filling up with fluid, like I said before. And quite commonly in heart failure, I see reports that have a patient with perhaps one-sided changes or asymmetrical changes, and the report has said something along the lines of patient likely has heart failure and concurrent infection or superadded infection cannot be excluded. That's a very safe way of describing it, um, because technically nothing can be excluded by imaging alone, and not to the absolute degree. So something like looks like this with the right mid zone clear, respecting the Fisher airspace opacity, somebody would very rightly call that as infection. Again, the point I was making before, that you need to call it consolidation and not infection, because consolidation can also be isolated pulmonary edema or flash pulmonary edema if it's bilateral. And this to drive that down, this one that you see quite predominantly involving the right base alone, almost looks like a tumor actually on this film, but has consolidation on the right and almost nothing on the left, resolved within a day with diuretics. So that was indeed only pulmonary edema or heart failure that looked like consolidation, which was consolidation, but looked like infective consolidation. The other point to take down was consolidation doesn't mean infection, and pulmonary edema doesn't mean heart failure. So when you see pulmonary edema on chest X-ray, in day-to-day workings, I rarely see anybody write cardiogenic or non-cardiogenic pulmonary edema. We say pulmonary edema, and the point to put into context in the back of your head is when you say pulmonary edema, you're just implying that the air spaces are full of fluid. You can't possibly tell why that is, especially if the heart is not enlarged. There's no sign on the history or the previous films that the patient is a known heart failure patient. Somebody going from a completely normal cardiac function to going to full-on cardiogenic pulmonary edema is low, unless they have a superadded event that pushed them down that route. People can go from non-cardiogenic causes of pulmonary edema that put so much pressure on the body that they ended up in heart failure. So they ended up with a mixed picture, that they started with non-cardiogenic, but now is a mixed picture or a full cardiogenic appearance of pulmonary edema. Other than the lung appearances alone can't point you one way or the other. The thing with pulmonary edema, though, is it changes very rapidly on chest X-ray. So the film from yesterday and the film from tomorrow will be drastically different. And the only thing that moves that quickly between imaging is fluid. So that's one way of telling whether that a patch of consolidation was actually fluid or infection. So coming to infection, is it active or is it old? If you don't have an older film to compare to, it's slightly hard. So look at that X-ray and give me a few clues of what you think. Is that an old infection or a new infection? I would ask people to turn their own cameras off if they can. Okay, thank you. So So yeah, automatically all of you were drawn to this atelectasis and started calling this old because you saw a bit of scarring. And like I told you before, the point I was making with architectural distortion, that this actually is ongoing active architectural distortion in more medial consolidation. So this is acute or subacute appearance of infection. And just when you only see a bit of linear change, that is very clearly chronic infection. When you see a bit of airspace Even in this one is perihilar, so it's a bit obscured, and hence the confusion. But when you see shadowing around atelectasis, it's not as easy to dismiss as it is when it's a clearly linear change. So be very mindful of dismissing it, uh, unless you have a previous film to compare it to. If this was absolutely the same as it was 8 months ago, then yeah, this is chronic infection. But if this was your first film, um, I wouldn't dismiss it as quickly as some of you have done. Okay. This is these are different patients, and I've put them just to give you an idea of what you want to look for when you're thinking of chronic versus acute or old versus new. On this one, very linear change, very clear linear atelectasis. So yes, old. Anything sinister looking about it? Anything particularly requiring follow-up? No. So this is, I would dismiss this in a heartbeat. This one, this is slightly more dodgy. On the coronal, you can see a bit of atelectasis around the heart, but when you look at it more closely, you see this thickening or soft tissue opacification next to the bronchus. So are you are you thinking this is all collapsed lung around the bronchus? This is subsegmental collapse, or is this actually a bit of thickening, active bronchial wall thickening or infection? This is a bit more indeterminate. But because this is so long, as in so smooth and linear looking, even if it is a bit thickened, the likelihood of this representing underlying cancer is low. So again, I would describe it, but I would dismiss it. I wouldn't recommend follow-up. This one, clearly linear atelectasis, so you want to call it chronic, but you have the surrounding ground glass opacification within it. Everywhere you see atelectasis, you have ground glass around it. So this is lung actively distorting itself, trying to heal itself while the active process is still going on. So this is probably subacute. This is active architectural distortion in a lung with active changes within it. So the reason for putting down active changes is the patient still gets treatment. They sometimes, particularly with COVID infections or atypical infection, they can get a bout of steroids, and that can really help improve their symptoms as well as their imaging. And the other factor to look for, obviously, in somebody, this is actually sarcoidosis, is you can look for the fissures or the tree and bud nodules or nodularity. So tree and bud nodules, sentinel nodules, fissural nodules, they all imply active disease, whether it's inflammatory or infective. I know it's not 7 o'clock. Before we start the lung nodule, I really want um, us to do the lung nodule bit in one stretch. So I take a 5-minute break here. And when we come back, we'll do the lung nodules, and I'll tell you all about the BTS guidelines and the morphology and the importance of calling something a nodule and why not to overcall it. So I will see you guys in 5 minutes time. Okay. Thank you. Most of you are back. The second half of let's say the middle third of the session, we will be focusing on lung nodule, and this is an Achilles heel for a lot of not only radiology registrars but also a lot of general radiologists. And I do feel, because the guidelines have changed so much in the recent years, many of us who are not thoracic radiologists feel a bit out of touch and lack the knowledge to be able to manage this adequately. Um, Somebody asked me in the chat to repeat the first 2 to 3 minutes of the lecture. This will be repeated here. What I was talking about in the beginning, and I will do again, is lung nodules. What is a lung nodule? Um, People use this term very flippantly, almost too casually. We don't realize the implications of it, and I'm hoping today you will. When we call something a lung nodule, we're calling somebody, we're labeling somebody with a focal lung pathology. And almost automatically, it starts a cascade of unnecessary follow-ups, unnecessary referrals to respiratory, unless they're all already with a respiratory consultant. I will focus on the UK-based guidelines. I will tell you how we are supposed to do it nationally, how the variation is across the UK, and depending on where you are in the world, you can either adopt or find the UK guidelines a bit useful in your day-to-day practice. Have it as a sense check to understand how you manage these, or if you have your own national guidelines, I'm sure you follow those already. So what is a lung nodule? Lung nodule is basically a focal lung lesion. Is an isolated, well-defined lesion within the lungs. Is there a size cutoff to call something a lung nodule? Absolutely not. A 2 millimeter lesion within the lung is a lung nodule. There is a cutoff of the largest possible size. So the cutoff is 3 centimeters. If a lesion is 3 centimeters or bigger, we then call it a lung mass. Below that is a lung nodule. So there is no minimum, there is a maximum size of a lung nodule. A lung nodule can have various morphologies. So it can be a solid lung nodule or it can be a subsolid lung nodule. When we come to lung cancers, we'll talk about the morphology in a bit more detail. But for the lung nodule purpose, when we come to lung cancer, I mean, when we talk about nodules alone, I want you to focus on two different morphologies. One is solid and one is not solid, or for the purpose of a guideline, subsolid. What that means is the all of the lesion is not solid. A lesion can have solid components. This lesion is still classified as a subsolid lesion because subsolid by definition means part of the lesion at least are not solid. By not solid, they can be ground glass, they can even be cavitating. So, yes, solid and subsolid. What to do when we see a lung nodule? The first thing, and the most important thing for a non thoracic radiologist, is to be sure that this actually is a lung nodule. The likelihood, the number of unnecessary referrals to a lung nodule clinic or to a respiratory service is unprecedented. It is unbelievable the amount of unnecessary referrals, and most of these are actually filtered out by the respiratory physicians themselves, at least at our trust. That's how much um, imaging we create as radiologists by unnecessary referring. So a lung nodule, if you pick it up incidentally on a study that was performed for something else, that means that the referrer was probably not a respiratory consultant. It could be a general physician. A general physician, or for example, a GI physician, wouldn't know what to do with a lung nodule, so they would automatically refer the patient to a respiratory physician. The respiratory physician, they actually have very good radiology eye themselves, so they sometimes they discount it themselves, or they would bring it to a nodule MDT depending on your local practice. There, the decision is either made or should be made whether to follow that nodule up or not. What ideally should happen is that the radiologist reporting the CT at the point of reporting should be clearly describing the nodule. They should be doing volumetry on the nodule. They should be referring them if required, dismissing them if required, or recommending adequate follow-up if required. What those means is there are very specific guidelines to follow, and they are very easily accessible on the internet, no matter where you are in the world. For the UK, these guidelines are from the British Thoracic Society. They were developed, I think, in 2015, and they are still the ones we follow. They clearly describe what to do with the initial presentation of a lung nodule and what to do on a follow-up um, scan. When to describe it as a nodule, the morphology that you can dismiss, the morphology that is clearly benign, you should absolutely be competent enough, confident enough to dismiss it, not overcall nodules, not generate unnecessary referrals. Similarly, your eye should be good enough to pick when a nodule is actually a real nodule, or more importantly, when it has clearly suspicious features. So by clearly suspicious features, we mean irregular margins, speculated margins, Brock score, and what I mean by Brock score, I'll come to later, something crossing a fissure, something changing morphology. So it was cavitating before, now it's solid, so it's clearly growing. Even if the size isn't bigger, the morphology has changed. So a change of morphology is very suspicious for cancer. The change of morphology in the other way, some people say that the solid one is now cavitating, so it's clearly benign because it's technically small, lesser soft tissue. Not always. Lung cancer can go through very many transformations along its course, and it can change pattern very drastically as well. More on that in the lung cancer bit. Uh, this section just focuses on a lung nodule. And don't forget the importance of history when you're reporting somebody with a lung nodule, because if somebody has a known history of cancer, these BTS guidelines go out the window. So these BTS guidelines only apply if somebody does not have cancer already. So if somebody has breast cancer and they had a scan and there was a nodule and you decided to follow the BTS guidelines, you would be absolutely wrong because the whole premise, the whole assumption is false in that case because the BTS guidelines take into account a lot of data, a lot of research, and this has been validated by a large population cohort in America and UK. The guidelines and the basic principle it's based on. So if somebody already has cancer or has known history of cancer, these guidelines don't apply. It's really important to remember. So this is again, like I said, these guidelines are easily accessible. They're free on the internet. You just have to write BTS guidelines for follow-up of lung nodules. There are 4 tables. It's a long document, so just focus on the 4 tables. I've put these 4 tables in the presentation today. They're immediately you look at them and you think they're a bit complex, but trust me, they're not. Because when you are looking at this table in your day-to-day practice, you would be looking at a specific nodule on a scan, and that's really that makes it really easy to follow it on the algorithm. So this one is the initial approach to solid lung nodules, and what you're looking for here is to call something a nodule that is not in a patient that has known history of cancer. It is definitely a nodule, meaning it is not benign. It is not a fleck of ill-defined ground glass opacification that was 2 months ago a consolidation. That's clearly resolving consolidation. It is a well-defined or isolated lung lesion. If it's the first thing to make sure is it more than 5? 5 is the magic number. 5 millimeter. If it is less than 5 millimeter, you can disregard it. You disregard it in a patient that has no current or known history of cancer. So you do not need to follow up any nodule, solid or subsolid, if it is less than 5 millimeter. What you do and how the first question I get is how do you measure a lung nodule? So it's the opposite of how you measure a lymph node. Lung nodules are measured in their largest diameter. So if it's an ill-defined or slightly ovoid or irregular nodule, you would measure it in the largest possible dimension. There is no right or wrong because this is just that number is just to give you an indication of probability of it being sinister, and what that number is giving you is something to follow up on. So ideally on a scan, you should mention the slice number that you're measuring the nodule on, and you give the exact millimeter. So there are no decimal points in nodule measurements. I very routinely see reports of 4.5 millimeter or 4.7 millimeter. I would say round it up or round it down, depending on whether they are. 4.3 is 4, 4.7 is 5. So no decimal points, millimeters in two-dimensional plane, less than 5 millimeter, you disregard it. More than 5 millimeter, you define the slice number. The actual recommended way is to do volumetry. For those of you who have volumetric softwares available in your trusts, many of us don't. So I don't know, depending on your local practice, if you have it available. If this is something you want to develop in your local trust, bring it up by all means. What volumetric softwares do, depending on different brands, different providers, is you click on the nodule on a software, you load the scan on that software, you click on the nodule, and it does a volumetric analysis of the nodule, depending on the vendors. So we have Singovia, so that doesn't, depending on the vendors, you can either edit the contours of the nodule on volumetry, or the software doesn't allow you to. Technically, the software shouldn't allow you to. And the reason for that is that the whole point of volumetry is to have absolute reproducible values for comparison. So if the volume today was 78, the volume next time would be independent. It takes away the variation of individual radiologist. So somebody has a tendency of overcalling, somebody has a tendency of undercalling. A volumetric assessment that a software does will be consistent and reproducible. So that is the reason we do a volumetric analysis. The other reason for doing a volumetric analysis is the change in volume happens before the change in 2D dimension. So a lesion can be stable at 12 millimeter for a year, but if you did volumetric analysis, you would see that the volume has significantly increased. And that is because of the three-dimensional nature of the scan and the three-dimensional nature of the lesion that may not be in the same plane as the scan. So that's the reason for doing volumetric analysis. The other reason for doing volumetric analysis is most of the lesions that we call as 5 or 6 millimeter are actually smaller in volume. So volume gives us more liberty. So if you do an initial scan and the volume is less than 80 millimeter cube, you can disregard it as benign, or you are allowed to disregard it as benign. If that comes back as cancer in 2 years, you can still look back and say you were following guidelines, so you were absolutely right to do so. There is no absolute certainty that even a 2 millimeter nodule is not cancer. So it's a balance of probability, how we report these. And again, the 80 millimeter cutoff also applies only if you don't have known history of cancer. Uh, so if they are under 80 millimeter, under 80 in volume, less than 5 in diameter, you can discharge them right then and there and forget about it. You can, for the purpose of good reporting, you can document it on the report, saying this nodule is less than 5 meter and warrants no further follow-up as per BTS guidelines in the UK. If they have previous imaging. So next step is that the lesion is more than 5 millimeter and or bigger than 80. You would then look for previous imaging. If they had previous imaging, that's a different story. But if they had no previous imaging, what would you do? You would recommend follow-up. Recommending of follow-up depends on how big the lesion actually is. So bigger than 5 millimeter can be 7 millimeter or it can actually be 27 millimeter. They're both lung nodules. But the likelihood of a 7 millimeter nodule being lung cancer is much, much lower than a 27 millimeter lung cancer. So then the next cutoff is 8 millimeter. So if it's smaller than 8 millimeter, you can recommend follow-up. If it's bigger than 8 millimeter, some trusts say or have a unsaid rule or a local standard operating procedure. If it's more than 8 millimeter, just give it to the thoracic radiologist or just give it to respiratory. Let them handle it because they can do the BROC and the MDT and all that. Depending on your local practice, if you don't have that, if it's bigger than 8 millimeter, you need to assess that lesion for risk of underlying malignancy. And how you do that risk assessment is a BROC model. I will come to the BROC model after I've gone through this. BROC model is just a way to put a number on it, put a likelihood of cancer on a nodule, on a specific nodule in a specific patient. If that model gives you a low risk of malignancy, so low is less than 10, high is more than 10 or equal to 10. Less than 10% of malignancy, it goes back to the follow-up algorithm. If it's more than 10% risk of malignancy, you need to do something now. You cannot afford to wait 3 months or 12 months because the likelihood of that lesion changing its stage, if it is actually lung cancer, is high enough to warrant action now. So if the lesion is bigger than 300 millimeter cube or it's bigger than 8 millimeter, you should assess it by the BROC model. If the risk of malignancy is more than 10%, you need to assess it with the PET-CT. PET-CT has further risk assessments. Then by that time, the lesion has already gone to a lung MDT or already gone for specialist referral. But this is important to remember from a registrar point of view, a general radiologist point of view, is then when you see a lung nodule, the first thing you need to assess it, is it a real lung nodule? Is it less than 5 millimeter? If you don't have volumetry, is it less than 80 millimeter? If you do have volumetry, no. And I need to either follow it up or I need to risk assess it. I need to risk assess it when it's more than 8 millimeter. If the BROC model is easily accessible on various apps on the internet, you can easily download them on your phone. The BTS app used to have that available for Android and iPhone. So lots of online sources. You can open up a lot of websites and just put in the specifics and it will give you a number. This is the follow-up for the same nodule. So the nodule is more than 5 millimeter, but it's less than 8 millimeter. So this is the follow-up. This is not that you're actioning now. We're not going for PET now. We're just thinking that this is a nodule. It's not screaming cancer now, but it's not I can't dismiss it, or I'm not supposed to dismiss it. What should I do now? So if it's 5 to 6 millimeter, you go straight for 1 year follow up. If it's more than 6 millimeter or equal to 6 millimeter, you do the 3, 12, 24. That's the take home message, the 3, 12, 24. And solid lung nodules that is not bigger than 8 millimeter, but is bigger than 6 millimeter, between 6 to 8 millimeter, you do 3 month follow up. If it's stable, you can go for a 1 year follow up. If it's stable, you go for a 2 year follow up. So for a total of 2 years, a nodule needs to be followed up. It needs to be, uh, ideally needs to have VDT assessment at every stage. VDT means volume doubling time. On the initial assessment, when you did the volumetry, you document it. So the next reporter at the 3 month landmark would not need to do the volumetry again. They would do the volumetry on the 3 month scan. They would see the volume on the initial scan, and they would calculate something called a VDT. VDT again is calculated on various apps, various websites. That VDT gives you an indication of the rate of growth. A rate of growth that more than 600 days is technically saying that the lesion won't double in size in almost 2 years. That is a slow growth that implies a benign growth. A benign lesion can grow, but sometimes explaining that to the patient is hard. So if you're saying, well, you have a lung nodule, but we don't think it's really sinister, but yes, it is growing. You need the guidelines allow you to ask the patient whether they would want that followed up. If the patient wants a lesion followed up that has a very slow VDT at the 1 year point, they can actually have it followed up at the 2 year point. But 2 year point is actually when the patient will be slightly more open to reassurance. If they are still worried at the 2 year point and the lesion has grown a little bit at the 2 year point, you can follow it up. But it's an individual nodule, individual patient sort of discussion. The guidelines won't take you beyond 2 years, but beyond 2 years, it will be guided by your local practice and the individual physician. The VDT of 400 to 600 days is actually just the right VDT for cancer. So these lesions should be assessed ideally with biopsy. Some patients don't want biopsy; they would rather wait for another scan. That's entirely reasonable. But when it's the VDT is less than 400, there is absolutely clear growth. If the VDT is in days, as in if the nodule was 5 millimeter today, next week is 10 millimeter, that sort of growth is too fast for cancer. That's the take home message that the VDT is in hundreds of days. The VDT of 4 days or 5 days is very clearly infectious or inflammatory. A cancer, no matter how aggressive, cannot grow that fast because cancer is actually cell growth. Cell growth takes time. It's not overnight, it's not in a week. So VDT very quick, exceptionally quick VDT is very clear indication of non-cancer actually. So yeah, VDT of less than 400, but reasonably um, slow to warrant cancer. I'm not saying VDT from 0 to 400. I'm saying, for example, VDT of 100 to 400 days. You should be very clearly thinking of cancer. You should work it up for cancer. And work up means they should have PET CT, they should have sampling, CT guided biopsy. If it's a medial tumor or right, paramediastinal tumor, maybe you can access it endobronchially. So definitive management means you have to aggressively chase the lesion, you have to characterize the lesion with PET, biopsy, and if it's not accessible for biopsy, if there is no local availability for CT guided biopsy, you can even have the surgeon take it out for even a diagnostic surgery. I will pause here for a few seconds, see if you guys are clear till this point, and make sure you don't have any questions that you're not clear on. So 30 seconds for questions, please. Okay, I'll go one by one. So less the VDT, the more aggressive the mass, malignant the mass. More aggressive meaning, yes, technically yes, but within a reasonable margin. The VDT of, like I said, days or hours is an inflammatory process, but with from 400, from let's say 150, 100 to 600, yes, the slower, the faster the VDT, the and the more aggressive the tumor. What is the cutoff of mass in nodule? 3 centimeter. Less than 3 centimeter is a nodule. More than 3 centimeter is a nodule, and more than 3 centimeter is a mass. 6 to 8 minute requires CT. Yes. Okay. Let's pause on the question so I can actually answer them. How accurate is CT in measuring nodules? So there's been quite some work done on it recently, saying that based on the degree of inspiration or expiration, there can be subtle change in the size of lung nodule on a CT if the nodule is at the extreme lung base. This is complex and research for the purpose of general radiologist, for the purpose of a registrar. The CT is extremely accurate in measuring a nodule, assuming that the CT quality is good, as in the patient isn't breathing all over the place. The most common mistakes uh, the surgeons do and the physicians do is they come back just before surgery, and I've had many such calls as saying, oh, so I was just about to take the patient to theater. I opened up the PET, look, the lesion's smaller. Should I be taking him to surgery? And I have had to explain this to multiple surgeons that this CT component of a PET is free breathing. I'm sure most of you know this already, but if you remember your physics, for the more junior radiologists, the trainees, is the PET CT images are required while the patient is slowly but clearly breathing. So in breathing, there is a lot of artifact. There is no real reasonable comparison in size between a CT PET and actual chest CT, diagnostic chest CT for measurement of size. So lesions can look bigger or smaller on PET CT compared to the CT they had for diagnostic purposes a week ago. That most of the time is artifactual. So don't go by comparing PET CT and CT, but yes, two CT is very comparable. Um, Let me maximize it so I can answer the questions. Is BTS guidelines only for solitary nodules? No. You can have 3 nodules and you can apply a nodule, but what will happen sometimes if you get too pedantic is, I had a CT today, there was one nodule on it, I recommended a 3-month follow-up. So the patient came for 3-month follow-up, they had another nodule. So now do I recommend a 3-month follow-up for the second nodule, or do I go for a 12-month nodule? And that is the question. If it's along the course of the 2 years, people can develop new nodules. And if you start a new nodule follow-up surveillance schedule for every new nodule, the schedule will get all jumbled up and it won't stop. So what I would say is, if the patient is on a follow-up for a first nodule, you follow that sequence. What happens in the middle, don't stop for it unless it's very clearly significant, because the likelihood of developing a new nodule in the middle of a nodule surveillance from scratch, and that being cancer, is very low. So if I didn't have a nodule today, 3 months scan, I'm following this nodule, and the patient developed a second nodule, that second nodule is not going to be cancer because it wasn't there 3 months ago. On the other condition being, on the first scan you had 4 nodules. So which nodule are you following? So I would say you have to document all 4. But if there are 10, pick the largest 3, pick the most suspicious ones, or how you can highlight the one you are more concerned for. But the guidelines are not only the guidelines don't apply for only when you have one nodule in the chest. It applies for any nodule. But the condition is they have no cancer. They don't have any known cancer anywhere else. Measurement in 2 dimensions are also okay. They are okay for the purpose of a nice report, a descriptive report, but the staging, the lung cancer staging, a nodule follow-up is based on one measurement, the largest measurement. So any other measurement you put in can be helpful for a surgeon for the purpose of, some people like doing a very descriptive report, but over time the more CTs you report, you faster you get, the reporting text gets minimal and you only end up with 1 dimension. Less than 5 millimeter nodule, solid nodule, warrants no assessment. Yes, absolutely no assessment. Less than Less the VDT, the more malignant. Yes. By nodule, we mean up to 30 millimeter. No. Third, you mean 300 millimeter? How to measure lung nodule on axial? You pick the longest. So if it's an axial slice, you measure the nodule to get the biggest number. Give the most pessimistic number, is what I would say. What is the nodule size lowest limit to pick up PET CT? Are you saying what is the size that the PET CT would be the most helpful on? Depends on your PET CT reporters. Some PET CT reporters won't give you a definitive diagnosis from less than 8 millimeter. Some will give 5 millimeter. But for the purpose of a radiologist, a thoracic radiologist, a general radiologist, I would say 5 millimeter is the minimum soft tissue you need. For example, if it's a part cystic nodule, part ground glass nodule, the solid bit you want is at least 5 millimeter for it, for to give PET a reasonable chance. Um, yeah, realistic for most centers is 8 millimeter. We do 5 millimeter. Anyway, to summarize the follow-up scheme, this is the summary. This is a screenshot of the actual table from the VTS guidelines. Will you measure on coronal sagittal to get greatest length or axial only? I would do coronal sagittal to get that greatest length, because the nodule doesn't know where the patient's head is and where the patient's foot is. It grows in any dimension. So you would want the greatest length in any dimension you can get. Okay, moving on. The second sort of follow-up and assessment is for subsolid nodules. So subsolid is a all-encompassing term for when we want to define a nodule that's not entirely solid. The non-solid part can be ground glass, it can be cystic. Um, so this includes all of those nodules. The only difference to remember, the main difference to remember is that the subsolid nodules are actually followed up for longer. So the solid nodules we follow up for 2 years. If they're stable, we forget about them. The subsolid nodules we actually follow for 4 years. And the logic for that is that the kind of lung cancers or malignancies that are subsolid, they are slower to grow. So this, because a subsolid lesion was stable in 2 years, doesn't mean that it will be stable in 4 years or 3 years. And that's the reason that it is followed up for 4 years. It is entirely possible, very commonly seen, that the lesion was actually still stable in 4 years, but 10 years from then, the patient, it slowly grew, or the morphology of the tumor suddenly changed. So again, this is just an arbitrary cutoff a society has put for us, but a nodule can change behavior anyway. But based on research and data and all of the work that the society has done and the Freshen guidelines have done, the cutoff is 4 years. The other issue with subsolid nodules, if some centers are not happy to biopsy them, very few centers, more specialist centers, actually do biopsy subsolid nodules. The reason for that is conservatively or conventionally it was thought that they were not cellular enough to give you a definitive diagnosis, and the fact that the risk of complications of a pneumothorax was too high to warrant it. And the third being that the other argument would be that it's a subsolid lesion, so it's clearly not an aggressive lesion, so we can wait a bit. So yeah, it depends on your local practice, how aggressive your surgeons are, what you have to offer the patient. So what is the point of proving minimally invasive adenocarcinoma in a 7 millimeter ground glass if you don't have a surgeon to take it out, because the surgeon needs to be able to palpate the lesion to take it out. So yeah, it's all defined by your local service, the ability to offer definitive treatment before you end up biopsying these lesions. Again, the sequence is the same. It's 3 months, 12 months, 1 year, 2 years. We don't do a scan in 3 years. We go straight for 4 years. So the only addition is the 4-year scan. The other difference is we don't do is it more than 5? Is it between 5 and 6? Is it between 6 and 8? It's only one. Either it's less than 5 or it's more than 5. That's it. For ground glass lesions, you don't need to worry about anything else. Less than 5, forget about it. More than 5, you need to do this the same 3 months, PROC score, high risk of malignancy, and all that. I will skip this because this is a bit complex, I think, because depending on where you are along your radiology training, I don't want you to get a bit too confused about wedge resections and what to do with. This is more catered towards um, thoracic radiologists. Coming to the Brock score, we've alluded to the Brock score. What is the Brock score? Brock score is just a number we calculate. It is a model developed from participants enrolled in the Pan-Canadian Early Detection of Lung Cancer Study. It is a validated score. It is used in lung cancer screening. It is used in clinical populations, and it is recommended by the British Thoracic Society guidelines for lung nodule assessment. What it does, it predicts the likelihood of cancer. It is a number that takes into account presence or absence of these specific risk factors. These risk factors are all that when they are ticked as present, they increase your likelihood. Older age, obviously, female sex, obviously. The reason being that the male population is slightly, the higher likelihood of having um, incidental lung findings in males compared to females, and that is a multifactorial reason that we shouldn't get into today, but it has to do with occupational lifestyle, smoking, etc. Then the family history of lung cancer plays a part, increases your risk. Emphysema, and not only implies underlying smoking history, even without smoking history, it implies damaged lungs. Damaged lungs are more prone to cancer, so that's a risk factor. Obviously, larger the nodule, the more likelihood, the higher the likelihood of it being cancer. The other thing is upper lobe nodule location. Um, can't exactly explain, but data clearly shows that the upper lobe nodules are more likely to be cancer. Part solid nodule type is more suspicious. Low nodule count. This is something to remember when somebody was saying, is it only applicable for solitary nodules? No, but with somebody having a solitary nodule in otherwise very clean looking lungs, is slightly more suspicious than somebody who has 10 nodules and, some atelectasis, some scarring, and 10 lung nodules. The likelihood of them being cancer would be low because they're likely inflammatory or post-inflammatory nodules or occupational lung disease. Speculation just means very speculated, very irregular, almost tethered margins of the nodule. You can sometimes convince yourself that you see that in infection. The way to remember it for lung cancer is when you see a nodule that is speculated, it means it is infiltrating into the lung around it. And when that lesion is next to a fissure, it inevitably pulls a fissure. So that's very suspicious marker. So if you see a CT and you do a coronal or a sagittal reformat and the nodule is actually pulling the fissure towards it, it implies malignancy. Like I said before, the first thing you need to confirm when you want to call something a nodule is to make sure this is actually a nodule. Intrapulmonary lymph nodes are very, very commonly um, described as lung nodules. Most of the unnecessary follow-ups come by this route that people have called just a benign looking lymph node as a nodule. Almost all of us have lymph nodes in our lungs that may be visible on CT. All of us do have lymph nodes in our lungs, small ones we don't see. Slightly, when they're large enough to be visible on CT, and they have a very typical appearance, they have a very typical distribution. When they have that typical distribution, any senior radiologist should be able to dismiss that as an intrapulmonary lymph node. And that unfortunately it doesn't hold true in UK or anywhere else. So just be very aware of the imaging appearance of an intrapulmonary lymph node. What it is most commonly is it's subpleural or it's peripheral. Peripheral, it can be towards the outside of the lung, or it can be towards the medial margin and the paramediastinal. It's still peripheral because it's the periphery of the lung, not the periphery of the body. It can also be periphyseal. So periphyseal means it looks like it's almost sitting in the fissure or it's next to the fissure. Periphyseal is still technically peripheral. It can be peribronchial. The morphology is very typical. It's called polygonal. Polygonal means it has sides, multiple sides. So those sides can be three. Most commonly, it looks like they have three sides. When you put them in coronary formats, they normally look like a rhomboid. Um, and if sometimes when you put them on a axial slice, they can look like a nodule, but when you put them on a coronal or a sagittal reformer, they look completely flattened. So that's also a very typical appearance of a intrapulmonary lymph node. When the lesion is technically in the right place that you want to call it a lymph node, you see features that make you slightly suspicious. And one of those features that people always get alarmed with is size. And the question I get is there a size cutoff? Is a lesion, can a node be too big? And the answer is no. A 1 centimeter node is still a lymph node. So you should be discounting it if it has a typical morphology, typical location. What is not excusable is the lesion was in the distribution of a lung nodule, lung lymph node, but the margins were clearly irregular. If the margins were irregular, or it was next to a fissure, but it looked like it was crossing the fissure into the other lobe, that's clearly malignant. So um, don't get into the habit of dismissing anything that is in the periphery of the lung. Yes, the likelihood of a nodule being benign is higher when the nodules are towards the periphery of the lung, or the 1 centimeter, 2 centimeter next to the fissures, paramediastinal space, the periphyseal subcostal space. But if the margins of the nodule themselves are irregular, it is not a lymph node. Or it is, you can say it's the atypical lymph node, or you're not entirely sure. So you can describe it. You can say the lesion is peripheral, subpleural, although the margins appear slightly irregular. Therefore, 3-month follow-up is recommended. When they come back for 3-month follow-up, they should be treated from that point on, or from the initial scan, as a lung nodule and followed up like a lung nodule. So atypical or a non-pulmonary lymph node morphology should be treated like a non-nodule unless proven otherwise and followed up the same way. So just looking at these two slides, give me some thoughts about these two. The first, this one, and tell me what you would do with it. And then we'll come to the second one. Okay, 30 seconds starting now. Okay, so the first one is a nodule sitting on the fissure, and assuming the fissure is going through there, this is clearly crossing the fissure, and the margins here are not polygonal. They're rounded there, slightly irregular there. Then this part is protruding beyond the fissure into the adjacent right lower lobe. So this is, I wouldn't be happy calling this or dismissing this. So rightfully, most of you have said a 3-month follow-up, absolutely right. This one, on the other hand, very flattened looking, almost ovoid, sitting in the fissure, very smooth looking. So this is a very typical appearance of an intrapulmonary lymph node, and this should be dismissed. So yes, 3-month follow-up for the first one, crossing the fissure. Second one, sitting in the fissure, ovoid, flattened looking, should be dismissed. So just summarizing it, on an initial CT, when we see a focal lung lesion and we want to call it or label it as a lung nodule, we need to describe the morphology of it. My morphology mean, is it solid? Is it subsolid? If it is subsolid and it has a solid component, you need to measure the solid component because that determines the risk or the next steps for now, if the Brock score was high enough. Uh, if it's subsolid and it has cavitating features or it has ground glass features, you need to describe them. If the lesion has some calcification, the initial thought is it's benign. But it's worth remembering in terms of lung lesions, uh, presence of calcification isn't always benign. And similarly for pleura. In lung and pleura, calcification does not mean benign. Fat means benign. So for a lung nodule, if you see calcification alone within a solid nodule, yes, the likelihood of it being benign is reasonable, but is it absolutely benign? No. And I would like you all to tell me what it can be that is not benign. A lung nodule with calcification, what could it be other than a granuloma? So sarcoidosis is a granuloma, right? Hematoma, yes. Carcinoid is the most important one that you need to consider. Some of you have said osteoblastic or osteosarcoma metastasis. Then you would obviously know of the body cavity cancers that can give you calcified metastases. But somebody having a single calcified um, metastasis from a colorectal primary, the primary wouldn't have gone missed. The lesion, primary lung lesion that can be calcified is a carcinoid. And that is the differential you need to always point out in real life as well as in the exam scenario. So if this was an FRCR to be exam and you were presented with a lung nodule that had calcification, you would need to describe that calcification. So flecal calcification, popcorn calcification have different differentials. So rather than use textbook terms, use your own terms. It gives you more leeway. It gives you more, it keeps your brain working, because sometimes we say a specific term and we get put down a certain path in a viva and it's hard to get out of it. So small foci of calcification, you would say that this nodule is partly calcified, suggestive of a benign pathology. However, this could also represent underlying malignancies such as carcinoid, or uh, possibly metastasis from what you guys have said. Although the likelihood, although primary may be known, may I know the history. So, like I said, calcified doesn't always mean benign, but fat means benign. When I say that, people automatically start measuring fat in lesions. So you people start putting region of interest on our packs onto the lesion. And if you try tomorrow, go to work, pick up any lung nodule, any lung lesion, any lesion anywhere, and make the region of interest small enough and hover over it, you will find microscopic fat. You will find negative densities in any lung lesion. So don't stress too much on measuring fat. The fat that means benign pathology in a lung nodule is macroscopic fat. What macroscopic means is you need to be able to see it with your eye. You need to see it like you would see it in a angiomyolipoma, you would see it in a lipoma in the skin or in the kidney. That that sort of barn door, absolutely visible to your naked eye fat is macroscopic fat, and that is the only feature that allows you to definitively call a nodule a hematoma and dismiss it. Does a hematoma always need a biopsy? No, when it has microscopic fat. When it has no fat, only has calcification, it is significant size, it's slightly irregular. Do you want to bank on the fact that it is a hematoma, or would you rather biopsy it? Bigger centers, complex centers would biopsy it. Size, I mentioned how to measure. You take the larger dimension. Most people do it on axial. If you were staging a lung cancer, you can do coronal, sagittal, measure it in multiple planes, see how it's growing. If it's growing in the longitudinal dimension, it could be 2 centimeter in the 2D. In the axial plane would actually be 5 centimeter in craniocaudal dimension. So how big is the lesion? The lesion is 5 centimeters, because the staging and the size determines the surgical field or the surgical planning. So there's no point on fixating on axial dimension alone. Does calcified mean benign? We've covered that. Type of calcification, the coarser, the thicker the calcification means benign. But have you seen coarsely calcified colorectal metastasis? Yes. Have we seen osteoblastic metastasis, osteosarcoma metastasis? Yes. Uh, we've gone over the follow-up of lung nodules. So we mentioned what we want to recommend on a follow-up. If the lesion is sinister looking on the initial scan, we want to recommend a respiratory referral now. We want it assessed. We want it assessed for PET. If it's a small lung nodule, the Brock score isn't that high, you want to recommend a 3-month follow-up. When it looks like a lymph node, but there are some features that make you uncomfortable about them, like the margins are irregular, it looks like it's crossing the fissure, you can recommend a 3-month follow-up. Uh, what you do on follow-ups is you look at the previous scan, you see if the morphology has changed. So a change in morphology alone is a very sinister sign. Even if the size is stable, even if there is no significant size in difference in VDT, changing morphology is sinister. The VDT is calculated by volumetric analysis on the first scan and the second scan. VDT softwares, volumetric softwares sometimes allow you to edit the contours of the lesion, but it is recommended that you don't do so just because it affects the reproducibility of the results. And when to refer the lung nodules is when you see sinister looking features, when you see nodules in a patient that has a known history of cancer or had known history of cancer. So it is not entirely uncommon for people free of cancer for 10 years, like malignant melanoma, like breast cancer, to present with lung nodules. If you look at their history and you saw they had breast cancer 5 years ago or melanoma 10 years ago, the BTS guidelines don't apply, is the point to remember. Okay. This is some of the differential because when we say lung nodule, people automatically think cancer, and this is just to put it into context that how many lesions, how many pathologies can look like a focal lung lesion or a nodule. Historically, tuberculoma, histoplasmosis, all the granulomatous diseases can look like lung nodules. But the thing with granulomatous diseases is the lungs around it are slightly abnormal as well. You see some calcification in the lymph nodes. So signs around it point you towards a specific diagnosis. Solitary metastasis, uh, as common as lung cancer. Benign tumors like carcinoid, always to keep in the back of your mind because they can stay stable for a long time. They can present with hemoptysis. They can mimic hamartomas. If you discount nodules for calcification, you may be caught out and miss a carcinoid. The lesion, the feature to focus on there is macroscopic fat. Inflammatory lesions can look like lung nodules, but most of the time, if you were used to reporting enough CTs, you would recognize the inflammatory looking pathology looks different. And most of the time, even if they are followed up at the 3-month follow-up mark, they can be dismissed. And you can put down at the end of the report that this requires no further follow-up. Granulomatous Wegener's vasculitis can look like lung nodules, but inflammatory pathologies, autoimmune pathologies that present with lung nodules almost always present with multiple lung nodules, but they can present as solitary. They evolve, they can get calcified, they present symptomatically. Interpulmonary lymph node sequestration, not always, but rarely can be called a nodule. Multiple lung nodules, it's slightly more varied. The differential, the the attenuation in multiple lung nodule is more a focus between solid and ground glass because the ground glass multiple lung nodules is a very different differential, and the most important differential for those are almost all non-malignant, whereas solid multiple lung nodules or calcified lung nodules is a slightly different distribution. We don't need to go through all of these, but this is just to put it into context in your back of your mind. I will again take a 5-minute break before we start on the lung cancer. We'll go through the chat questions. Give me 1 second. Okay. If on the first CT there is a lung nodule identified, then follow up there is new lung nodule. How do you arrange the follow ups? Most of this is common sense oriented. So, if on the first nodule, first scan, let's say you were following a 8 millimeter nodule, and on the second scan, the patient developed another nodule that was 6 millimeter. The like you aren't that worried about the 6 millimeter nodule. So I would say instead of putting the patient down multiple follow-ups and in the end not being able to determine when the surveillance actually finished, what you would do is you would stick to the first follow-up. For if on the second 3-month follow-up you develop a new lung nodule, the likelihood of it being malignant is low. It's likely an inflammatory nodule, and an experienced radiologist would be able to dismiss it. The problem comes when it's a 1 year follow up. So at the time of the 1 year follow up, if they have a new lung nodule that warrants follow up, but they have the older one, I and most thoracic radiologists would recommend that don't change the follow up, stick to the 2 year follow up, don't add another 3 month follow up. But at the point of the 2 year follow up, somebody will realize that the second nodule came only a year ago, so they need another year follow up. So the length of the surveillance would probably increase, but don't increase the frequency of the interval scans because you know that the patient is coming back. The reason for follow up in 3 months' time is only one. The reason people have a 3 month follow up is to give the lesion a chance to disappear. If the lesion hasn't disappeared on the 3 month follow up, it's real, is basically a rough way to look at it. So if the lesion came on at a 3 month scan, you know it wasn't there 3 months ago, so it's likely inflammatory. If at 1 year point or the 3 month point rarely you see a lesion that really worries you, you think it's 11 millimeter, it's a bit speculated, it's the location is too medial, for example, it's right next to the pericardium, so you know if that grew significantly it can eat into the paraintestinal that structures, it can change the staging. So I don't want to take the risk. You can upstage the management at any point, but for any small lung nodule, 5 to 6 millimeters, 6 millimeters, 7 millimeter, stick to the original surveillance program, give the patient a chance because you know they are coming back. That was the first question. I think the second question was, is if history of primary tumor, BTS guidelines are not applicable. Yes, they are not applicable if there is history of malignancy anywhere in the body, not just in the lung. Current malignancy or previous history of cancer, they are not applicable. So how to follow lung nodules in this scenario? You wouldn't follow them up. You would, if there is a real lung nodule, if somebody who has known history of malignancy, you need to escalate it. You need to refer it to the appropriate MDT. If the patient had breast cancer 5 years ago, they have a new lung nodules, you need to refer it to the the lung MDT, because the current lesion is in the lung. Because that if metastatic disease is still potentially curable, the patient in this day and age has multiple avenues available to them. There is ablation, there is a wedge resection, there is saber, all sorts of stuff they can have. So you can't dismiss it, you can't wait. You have to escalate it to the appropriate MDT and let that specialist team make that decision. And that decision is made uh, in the context of the patient fitness, the oncology team, the surgeon team. It is not something that should sit with the radiologist. So that absolutely needs to be a lung nodule that is not clearly benign in a patient with known history of current or previous malignancy needs to be assessed in a formal MDT for next steps. Because in most cases, if accessible, we would biopsy them. Regarding Brock criteria, is it the female or the male sex that is more prone to lung cancer? The Brock, it's not about being prone; it's about the likelihood of a nodule being um, in a lung in a female being real. So the logic of that, the more prone to lung cancer. It's a fun fact that you guys may not know that in the developed world now, the rate of pickup of cancer in females is actually higher in the young population. So if by young I mean 30 to 49. So in that age group, females are actually the higher group being diagnosed with lung cancer. Some say that that's because of the affluent populations increased smoking in females. And the other argument is that the female gender is slightly more aware of its health and slightly more prone to seek help or follow medical advice compared to the male gender. Um, so on the Brock score, yes, when you add the female gender, it will increase the Brock score. If there is no volumetric software, can you manually measure 3 dimensions and calculate lung volume? No, no is a simple answer. It's not a mathematical assessment we make. The volumetric software, what it does is creates a 3D volume of the lesion. So like it creates a ball shape, or it follows the irregular shape of the nodule in the 3 planes, and it gives you an accurate assessment of the nodule. And a mathematical calculation can't do that. So if there is no volumetric software, you're absolutely allowed by the BTS guidelines to follow your 2D dimensions. What are the standard number values in Brock score? There are no standard. It's not. There is no score that is normal. The score is just to give you predict a likelihood of cancer, to guide your next decisions. The rough score we judge high or low risk by is 10%. So a Brock score of less than 10% is low risk. A score of 15% is high risk. A score of 78% is also high risk. So there's no standard value. Uh, why the set point is always 3 months, ma'am? Why not 4 or 2? I can't answer that. I'm afraid it's what the society decided because you had to put a number, a number down somewhere. So I'm guessing this is based on thousands of patients, if not millions, and data and research showing the rough or the approximate time that you allow a lesion to grow. So 2 months is sometimes we do follow lung lesions up and recommend a 6 weeks follow up, but that's for clearly um, inflammatory looking lesions, or clearly when it's very urgent that you come to a clear diagnosis. And what I mean by that is, for example, if it's a chemotherapy patient, or if it's a patient that has cancer and they responded to radiotherapy and suddenly that area of the lung is now completely white. And the question immediately will be, is it chemo induced? Is it radiotherapy change, or is it cancer? You've done your contrast scan, you've done your PET. There's no point of doing a PET because it will light up anyway. But you can't make the clear distinction between a recurrent or progressive disease or a post-treatment change. So what you would do in that situation is sometimes they would give, if the patient is really unwell, you can sometimes go for a 6 weeks follow-up, which is a very specialist-oriented thing we sometimes do. Is when we want to make a quick decision. Even for quick decision, a lung needs at least 4 to 6 weeks to do anything, because the improvement in radiological appearance lags behind. The patient can improve in a week, but the lung appearance will not improve in a week. It needs more time to show visible change. And that is the one thing we noted, and it was actually recognized internationally with COVID, because with atypical infections, particularly like COVID, they need longer to do something. They need longer to get worse, to get better. So that's why all the thoracic radiologists were trying to explain to people that you can't treat a CT scan in COVID patients. You can't treat an appearance on a CT scan, because the appearance on a CT scan today doesn't tell you what the patient is like today. If the patient is better today compared to a week ago, the CT scan will be better to reflect it in slightly longer than that. So yes, we can do a shorter interval follow-up, but those questions are generally different. Those questions are usually custom tailored for a specific patient, a specific scenario. And the question is usually about, is it progressive infection? Is this progressive disease, metastatic disease, malignant disease? Is it treatment pneumonitis? For lung nodules alone, a generic guidelines based across multiple countries. For this country, BTS guidelines is based on an insane amount of data, and they've come to a 3-month number, and that's what we follow. What if a lesion, this is a very good question, what if a lesion decreases from 6 to 4 on a 3-month follow-up? Shall we discard it now? No. And I'll tell you why. A nodule can change in size. A lung cancer can get, this is a scientifically proven fact, a lung cancer, a cancerous nodule can get smaller and then get bigger. So a nodule that got 6 to 4, could it still technically be cancer? Yes. Why is that? It's because it induces almost a fibrotic reaction. It pulls the lung around it. So on a radiological technique, what you will see is that it looks a bit smaller. Change is very subtle, but it is a well-documented fact that cancerous lung nodules can get slightly smaller. So don't be overambitious. Don't discard it. Follow it. 1 year scan, you will be more than able to dismiss it if you wanted to. So I hope that answers everybody's question. We'll move on to the last part of the session today. Is the lung cancer bit. So lung cancer is one of the most prevalent cancers in the world and UK. About 50,000 patients are diagnosed with lung cancer every year in the UK. It is one of the largest or the largest cancer MDT in any trust. There are various pathways developed across the world to manage suspected lung cancer, to image them, to get definitive tissue diagnosis, to manage them treatment-wise. I will focus on the UK bit. I will also tell you variation across the UK, and also tell you about the signs and symptoms that are very suspicious for lung cancer and how primary care and secondary care manages it differently. I will also touch a bit upon lung cancer screening. So the UK is one of the countries that currently has a pilot of lung cancer screening running. The pilot has expanded to almost 50 sites, will be expanding to almost 50 sites now, and will probably be going national. So the aim of lung cancer screening, just like breast cancer screening, is to find cancers earlier. The basic principle for screening is to downstage disease. It is to find the same cancers earlier at a time they could be managed safer, more efficiently, and be offered curative treatments, because a lot of lung cancer, like any other cancer, is presenting with end-stage disease, stage 4 disease in an ED, with the incidental diagnosis of lung cancer, and the screening programs are aiming to address that. So downshift of the staging, and obviously it goes side by side with preventive measures, the preventive measures being smoking cessation, and lifestyle choices. So focusing on lung cancer, there are some symptoms that are very clearly suspicious of lung cancer, and the number one symptom of that is hemoptysis. But every hemoptysis is not lung cancer. And when we say hemoptysis, it's very important to say, remember that the guidelines or the documents say unexplained hemoptysis. So if somebody has a foreign body stuck in their trachea and you pull it out, they will have hemoptysis. If somebody had a biopsy or they had trauma, they would have hemoptysis. So unexplained hemoptysis is suspicious for lung cancer. A hemoptysis with a cause like bronchiectasis or infection is very common to present with. Hemoptysis is not suspicious for lung cancer. Unexplained hemoptysis in men over or adults over 40 years of age is a higher risk. In some places, including us, we have a straight to lung cancer or rapid diagnostic cancer pathway for lung cancer. And what that means is when you have a certain symptoms that trigger you on a 2-week wait lung cancer pathway, you are seen, since COVID, virtually seen by a lung cancer specialist, be it a nurse or a doctor. You're advised a CT scan the same day. You walk in, get a CT scan, and you report it the same day and have a next day MDT. So that's a very rapid diagnostic cancer pathway. Very few centers in the UK do that. Well, almost one or two do that. The optimal lung cancer pathway, however, was developed by the UK a while ago, and it's a very aspirational document. I will show you that document in a bit. It's slightly complex, but I will ask you to focus on the first 3 days of the optimal lung cancer pathway. It was updated in 2020, and this was due to COVID. And you may or may not know that COVID caused a lot of delay in lung cancer presentation, because a lot of patients sat at home thinking they had COVID when they actually had lung cancer. Because some of the symptoms can be mimicking one or the other. The thing most striking about this is that the time given on the optimal lung cancer pathway from presenting to making the diagnosis, whether the patient has cancer on imaging or not, is 3 days. That is nothing. 3 days is barely enough time to, for most centers to schedule an appointment, let alone scan, report, and discuss. The bulk of the patients are sitting in primary care or sitting in the community. Then there is the cohort of the patients that present in ED, and these are the patients that present with advanced stage cancer because they've presented unwell enough to present to the ED. Unfortunately, there's a very high number of that. So that is what the screening program is trying to address. So initially or conservatively, the ask was to do a routine chest X-ray or an urgent chest X-ray to look for cancer. But we now know that X-ray is very low sensitivity for excluding small stage lung cancers. So if you have a high enough clinical suspicion, you should ideally be going for CT. The way we do, we go straight to CT. We don't bother with the chest X-ray, especially when you have somebody with 40 plus who has hemoptysis. You deserve a same day. You ideally need to have cancer excluded with a CT, regardless of what the X-ray may or may not show. The only reason sometimes trusts or regions go for X-ray is when you want to look for alternative pathology. So for somebody clearly has infection or bronchiectasis or chronic disease, you can have hemoptysis. But like I said, you can have bronchiectasis or infection and still have cancer. And with the low dose CT scanners and ultra low dose CT scanners, you should be having a CT chest. The what we call stopping the clock is when we say that the diagnosis has been made, whether the patient has had cancer or not, based on the optimal lung cancer pathway in the UK. Both the respiratory physician or the radiologist has the right to stop the clock. And by stopping the clock, it means that the radiologist has reported the CT and they have determined that the patient does not have cancer. At that point, the patient can come off the cancer pathway with a clear diagnosis that they can be discharged. If they have findings suspicious of cancer, they need to have a fast track lung cancer clinic. Fast track lung cancer clinics have a very high number of CNSs, nurse practitioners who support it, and they do a very good job doing it. The reason for a fast track lung cancer clinic and a fast track MDT is the radiologist and the respiratory physicians can look at a scan together and decide what is the next step. The next step is tissue diagnosis. We need tissue diagnosis to determine not only the likelihood of response to treatment, but also the staging, confirm the staging. So ideally, you should biopsy a site that would upstage the disease. For example, if I was reporting a CT abdomen pelvis, chest abdomen pelvis and I suspected a lung cancer, and the patient had a liver lesion or they had inguinal lymph node, let's say, or a bone lesion, I should be technically be targeting those sites because a confirmed tumor in those sites is actually confirming the stage in the same go. Because if you go for the lung lesion and then biopsy the bone, did not biopsy the bone lesion, that somebody can come around and say, well, are you sure that the bone lesion was caused by the same lung cancer? And the answer is no. Of course, you have the PET avidity and the clinical scenario to go to, but ideally you should be going for a site to tissue to upstage the disease to the highest it is suspected to be. Beyond that, diagnostic bit, I won't dwell too much on the treatment options because obviously as a radiologist, you guys wouldn't be too involved unless you do choose cardiothoracic as a specialty. I will focus on some ways that lung cancer can present. So obviously there is the signs, symptoms like hemoptysis or unexplained weight loss or chronic cough and stuff like that. But what on imaging can make you suspicious for underlying lung cancer? And the appearances that you often get presented with, at least in exam scenario or real life even, is findings, ancillary findings. So you can talk about diaphragm or pleural effusions. So we'll go through those one by one. Unilateral elevated hemidiaphragm. If some of you may remember that we covered this in the first session. So unilateral elevated hemidiaphragm implies that the diaphragm is paralyzed. Can a chest X-ray tell you that the diaphragm is paralyzed? The answer is no. These previously used to be assessed by ultrasound or even fluoro, but more and more centers sometimes assess them with MRI. The first step to do with unilateral hemidiaphragm, particularly in a patient that has unexplained weight loss, is to look for underlying lesion that may be pressing on the phrenic nerve anywhere along its course. So remembering the anatomy, the phrenic nerve goes along the mediastinal margin there, all the way there. So any lesion along this course pressing on the phrenic nerve can actually give you phrenic nerve palsy and cause the hemidiaphragm to be elevated. Causes above the diaphragm is where we are concerned with. So lung collapse, pleural disease um, can all cause it, but the one we are most concerned about and want to exclude with cross-sectional imaging is a CT, is a lung cancer. In this case, you can see that the lesion sitting here pressing on the phrenic nerve in the superior mediastinum is causing unilateral elevated hemidiaphragm. The other way lung cancers can present is unilateral hilar enlargement, and where sometimes people get stuck, especially in viva situation or exam situation, is they look at it and they get stuck immediately thinking, am I supposed to call it hilar enlargement, a lymphadenopathy, or is it a hilar mass? Um, and the answer is you can't tell that by looking at a chest x-ray. If you get stuck in exam, the word you want to focus on is hilar enlargement. So that covers both. Um, is the easier way or the textbook way of what they might want you to point out is um, can you see normal lung around it? So in this case, because you can see normal lung around the medial aspect of it, that suggests that the lesion is sitting inside the lung. Whereas here, you can see that it's coming out of the hilar margins, and these margins are actually quite obtuse. So this suggests this is in coming out of the hilum. Um, so unilateral hemidiaphragm elevation, unilateral hilar enlargement, which may be lymphadenopathy from a tumor that you can't see because the tumor is either hidden behind the heart or in a location or a density not high enough to be visible on chest X-ray, or that lesion, that hilar enlargement itself can be the lung primary. So there are a lot of tumors that sit more centrally depending on the histopathology, and we'll come to that in a bit. Unilateral pleural effusion. In an unexplained pleural effusion, unilateral, is cancer unless proven otherwise. That is absolutely something you need to take home, need to remember. If you can't explain a pleural effusion, unexplained pleural effusion in the adult is cancer unless proven otherwise. In an 18-year-old, a university student, an immigrant, you can put in primary TB, higher than malignancy. The same patient, if they were 70, if they were a smoker with 80 pack years, that's lung cancer unless proven otherwise. Sometimes you even do CT and you can't see the primary. Sometimes the pleural effusion has cancer cells and you can't see the primary even on CT. But you absolutely need to recommend next steps when you look at X-ray like that. So a large pleural effusion, moderate sized pleural effusion, without a cause, no trauma, no hemothorax is suspicious for underlying cancer. Having said that, the same patient with the known, hepatic failure or um, stomach malignancy, renal failure, cardiac failure, infection, some collagen vascular diseases like SLE, autoimmune diseases, um, and they can present as pleural disease as well. They can, but the likelihood of them presenting as a unilateral large pleural effusion is slightly lower, and like I said, needs exclusion for cancer. Trauma, obviously, you can't have a pleural effusion like that go undiagnosed because they must have had significant trauma to cause that. Coagulopathy, rare. Again, if somebody is on blood thinners, they can technically have effusion that big, but they would have had some trauma. In their case, even minor trauma can cause that. Pleural endometriosis is a very, very rare cause, but yes, it can be. Pleural effusions can also be caused due to an extrathoracic disease. So these are diseases outside the chest, but they're inflaming the diaphragm inferiorly, or it's a systemic issue with hemodynamics, with protein imbalance that can give you pleural effusion. The likelihood of those being unilateral, again, lower. So if you have unilateral pleural effusion and there is a small or asymmetrical one on the other side, it's more reassuring. Um, and the likelihood of somebody presenting with post pancreatitis and having an asymptomatic pancreatitis is extremely low. So history comes into play then. This is just an infection. This is a slide showing you almost a complete whiteout of the left chest, a bit of the left upper lobe left over there. So unilateral large pleural effusion, but you can see that they have monitoring on, and the patient is unwell, judging by the wires and the leads you see on the film. So unilateral pleural effusion in a cancer patient is usually the patients are extremely well, or almost they they almost always present at outpatient. So they may increase, they present with they get a bit breathless when they lie down flat, or they have had loss of weight that is a bit unexplained. Um, Whereas if that bigger pleural effusion was caused by infection or inflammation, the patient is symptomatic. So that's one way of differentiating it. So that large pleural effusion here shows, just going to move this away so I can see what I'm looking at. So this one I've put in just to show you the pleural thickening. Again, very commonly underdiagnosed, overdiagnosed pathology is pleura. Pleura, again, the differential is infection versus malignancy. One way to differentiate infection versus malignancy in the pleura, uh, that you one way that we do it in the lung that we can't apply it to pleura is the previous film. Whereas lung, the malignancy is slightly slower to progress. Pleural primary malignancy is extremely fast, extremely aggressive. So it's one of the scarier malignancy, and some of us get told in our training that if you missed a mesothelioma, by that part you missed it, the patient would in 6 months time would be dead. So there is no leeway there of follow up. So a pleural thickening is slightly managed slightly more differently, because if you are suspicious or indeterminate appearances, or you're not sure, the point of intervening is the first presentation, because you don't have time to wait. You can't do a 3-month follow-up or a 6 month follow-up on pleural thickening, because if it was malignant, it would progress rapidly to the point of no return. um, Mesotheliomas are rare malignancy, but extremely aggressive malignancies with a very low survival rate anywhere in the world. So the thing with this pleural effusion that I'm showing you on the slide is I want to show the mass effect that it's causing. In pleural infection or an empyema almost acts like a solid mass. It acts like a balloon that pushes other structures away. And what it does is it makes it that you can see both sides of the pleura. What I mean by that is the pleural anatomy. So we know that there is a visceral pleura and there is a parietal pleura, and fluid sits between the two layers. When pleural infection happens, it expands that space. And on the previous one, what I showed you was that you could see the visceral pleura and you could see the parietal pleura both thickened, and they were both thickened, but they were both smooth. You could not see any irregularity. You could not see any nodularity. There was nothing suspicious about it. And the pleural effusion itself, even if, sometimes it's high density, but even if it's not high density, it was causing this almost mass-like effect on the lung around it. That is all feature. All these features are very suggestive of pleural infection or an empyema. Something people get very confused with is defining uh, lesions around the pleura or inside the pleura. One way to think about that is always imagine the pleura as a space. So you know that there is a pleural space. Ideally, you shouldn't be able to see the pleural space. If you see fluid in the pleural space or abnormality in the pleural space, only then are the two layers of pleura visible separately. Otherwise, you can't tell them apart. So when they separate, the pleura that sits on the lung is the visceral pleura. So the most common thing to diagnose the overcall is something called as a pleural lesion, where it's actually a lung lesion that is sitting right next to the pleura. So parenchymal subpleural lesion looks like that. Can you always see that differentiation, that space? The answer is no. You can see that space when there is extrapleural fat. If you see that lesion and then you see fat over there, that you are reassured that this is sitting inside the lung. If if somebody asked you that, well, couldn't that lesion technically be arising from the visceral pleura? And the answer is yes, but what grows from the visceral pleura and grows into the lung? Nothing. if the visceral pleura was growing something, it would be growing it in both directions. Um, this is a lung lesion. It is an aggressive lesion. It is growing outwards. This technically could still be a visceral lesion, but it's clear that it is aggressive. An aggressive lesion, pleural malignancy is rarer. So the likelihood of that being a peripheral lung malignancy is much higher than being a pleural malignancy. So that alone makes the, on the balance of probability, you would call it as a lung lesion. Extrapleural fat. Some people have very prominent extrapleural fat, and some registrars really forget to window it. It just takes one click on a keyboard. Uh, Many times people call it as pleural effusions just because you could see it very prominent on a lung window CT scan. So just click on the fat on the mediastinal window, and you would clearly see that all that thickening is actually fat. Having prominent extrapleural fat is normal. You could see it in thick patients. You could see it in certain people who are even not thick, but they are slightly more prone to it. Some people have very prominent mediastinal fat, but the two can be separate or together at the same time. Uh, so the take home message is a peripheral lesion that is irregular on the lung side is likely sitting in the lung. The thing to look for in that situation is extrapleural fat. If you see clean extrapleural fat, you are reassured. If this was malignant, the likelihood of this, you have to assume this has involved the visceral pleura. That is okay. What this clearly shows that this has breached into the extrapleural space, and this in this case has actually gone into the intercostal muscles and acts involving the chest wall. So that these both of these two situations upstage the disease if this is cancer. Uh, the extrapleural fat can be very prominent. There can be lesions that that grow in the extrapleural fat, and the most common one of those is the extrapleural or the pleural lipoma. You can see a very prominent or even a lobulated overt opacity there. You don't need a follow-up, you don't need a biopsy unless you see solid components in it or they are causing patient symptom. The likelihood of that is extremely low. This is just to drive home the message I said before, is when you see pleural thickening, you need to look for irregularity, you need to look for nodularity, and you need to look for enhancement. On an arterial phase scan, if the pleura is not enhancing, does not mean that it is not abnormal, because the pleural phase of enhancement is at least 55 to 60 seconds. So if you want to assess pleura for enhancement, you don't do it on an arterial phase CT scan. If the primary question is underlying pleural disease, benign or malignant, you need to do a 60-second delay CT scan with contrast, because that is the optimal time for enhancement of pleura, whether that's chronic inflammation, active inflammation, metastatic involvement, nodularity, primary mesothelioma. Either way, 60-second is the magic number. When you see pleural thickening in a scan that wasn't there on the previous scan few months ago, or there isn't a previous available, these features that you look for become very, very important, because if this patient has primary pleural malignancy, it will progress very, very quickly. You do not have time to do a follow-up. You need to recommend something now. Fleck of calcification, people automatically get reassured. What that means is chronicity, but that can also happen in asbestosis. So people who have exposure to asbestosis have pleural calcification. They can have pleural thickening alone. They can have calcified pleural plaques. They can have non-calcified pleural plaques. They can have a combination. When they have bulky calcified pleural plaques bilaterally, it becomes a very easy diagnosis. But when you have somebody like this who has just a fleck of calcification, can you assume that this is previous inflammation, or can you assume that this is malignancy? And the real answer, no matter how experienced you are, looking at that scan, that slice, is that you can't tell, because that fleck of calcification can be remnant from previous pleuritis or tuberculous empyema that was drained 20 years ago, or that can be a fleck of calcification in somebody who's been exposed to asbestosis. Being exposed to asbestosis automatically increases your chance of likelihood of having mesothelioma uh, quite a lot. So in that context, when you see this pleural thickening next to it, the non-calcified bit, you can see that this is quite thickened. Then it gets thin. This thin rim is reassuring. This thick rim is worrying. Then you see the fat next to it. You are reassured. Then you see the calcification and you start to wonder. So this thick, this extra pleural fat is not hypertrophied. When you have infection or when you recover from infection, what extra pleural fat hypertrophy suggests on CT and imaging is that this is benign. This is not enough to qualify as hypertrophy. So in this case, what would you do? Would you dismiss it? Would you recommend follow-up, or would you manage it aggressively? And what I would like you to do is refer it, because there is fluid behind it. It is easy to sample. This pleura can be biopsied under CT. This pleura can be biopsied with a scope and a respiratory physician. This fluid can be sampled, if nothing else, for cells. Uh, the pleura is strikingly acellular, so it's more likely to get a non-diagnostic biopsy from a pleura than it is from a lung, just because of the way the cells are spaced out more. So you ideally want two negative biopsies from a pleura to be reassured that it is benign, and that is why we end up going the scoping thoracoscopy and that route more than CT guided. But if there is a small bit that you can't really find on an ultrasound or a respiratory clinic, we do end up going in with the CT guided route. Um, this one right here, you can see progressing exponentially, encasing the whole of the chest, extending into the fissure, getting very thickened, um, very lobulated, enhancing, and this was mesothelioma. Okay, I'll pause here and see if you guys have any questions. Okay, I think you guys are answering this one. Okay, let's move on. This again shows a significant size pleural collection on the left side. But what I would want you guys to consider is the shape of the collection, and then give me what you are favoring. Are you favoring infection or are you favoring malignancy? Okay, 30 seconds starting now. Okay, I think most of you have called it right. Um, this is indeed infection, and the reason it is infection is what I said before, that the empyema or infective pleural collection almost acts like a mass, because sometimes because of the thick contents or because it is inflaming both the visceral and the parietal pleura, so it's actually just stuck in that place and it expands in that place rather than go up and down. It can extend into a fissure, and when it extends into a fissure, it can almost look like a tumor on a CT. But this rounded bit, this almost mass-like bit originating from the CT side, um, is more suggestive of infective pleural collection or an empyema. With the malignant effusion, you just want seeing rising like that. So well done. Okay, this one, just have a look at this pleural-based opacity and tell me what worries you about this. And sorry about that. So this, I think, is just the slice that it's at. It looks like there is a rib, that rib is missing. It's actually not, but there is clearly extension outside going into the subcutaneous tissue. Um, can anyone tell me what that's called when an empyema extends into the extrapleural tissues, then into the chest wall? Yeah, perfect. That's absolutely right. That is empyema necessitans. So that's a pleural collection that's ruptured into the through the parietal pleura and creates an intrathoracic and an extrathoracic component. That can also present as a sinus, as a draining pus sinus in the chest. But most commonly, it looks like that without an outlet into the um, outside the body. This one, this is just to trick you guys a bit and see if you remember a certain point I told you a little while later. So this is a lesion or a pathology centered on the rib. Give me a few differentials for this and tell me if you favor one over the other. 30 seconds. So my question here is, if it's an aggressive lesion that is eating the rib, why is it not eating the fat, the extrapleural fat? Why is it respecting it, displacing it, rather than going through it? Yes, perfect. Yeah, that's a rib fracture. The hematoma around it. That's why the fat is preserved. So that's just to drive home the message that the history is very important. There's almost soft tissue pacification, high density, uh, than you would expect with simple fluid centered around the rib. The rib is broken. So that's a rib fracture with associated hematoma. Coming to the morphology of lung cancer, it's like I said, with lung nodule, the morphology is variable. With nodules, we just classify them as solid, subsolid, subsolid encompassing everything else. With morphology of lung cancer, when you have definitive diagnosis or when you're reporting a known lung cancer or a staging scan, the reporting of the morphology gets slightly more elaborative. So for solid, it's solid, it's spiculated or irregular. That's defining the margins. Sometimes you can have low attenuation materials, so that shows up only on a contrast scan. A very prominent necrosis can look like low attenuation even on a non-contrast scan, but that is still a solid tumor. If you get you know cavitation through that necrosis, you can say a necrotic tumor. For a subsolid lesion, they can be purely ground glass. They can be part solid, part cystic. They can be part solid, part ground glass. And that all depends on the individual histopathology of the tumor. So previously, what was called as adenocarcinoma in situ, minimally invasive adenocarcinoma, invasive adenocarcinoma, we now know that this is a continuous spectrum. By continuous spectrum, we don't mean that a carcinoma in situ slowly goes into a minimally invasive and goes into an invasive, like a linear pattern over time. That would be ideal because that would make predicting and following up much easier. But the reality and the truth is, a minimally invasive adenocarcinoma can suddenly change pattern any time, and it can suddenly become very aggressive and change the growth pattern at any time. So what is minimally invasive today may remain minimally invasive 5 years from now, or it can suddenly change pattern in 2 years' time. and become aggressive invasive adenocarcinoma with metastatic disease. That's the unfortunate truth about malignancy. One way of arbitrarily giving a differential diagnosis is with there's sometimes more central tumors. So the likelihood of more central or mediastinal based tumors presenting with bulky nodes, central masses is some small cell cancer. Small cell cancer being very rapidly progressive, but it also responds very well to treatment if caught early. That's a rough morphology of lung cancer. Radiologically, this is what when somebody says lung cancer, you automatically imagine something like this. You expect a mass lesion that has clearly spiculated margins, and that's very easy to diagnose for the most general radiologist. But the tricky part comes when you come to different morphologies of lung cancer. This, if it wasn't for the pleural, the fissural crossing or the fissural involvement into the two lobes, on certain slices, somebody may, in speed and haste, dismiss this as post-inflammatory atelectasis. Because you see the lesion crossing the fissure, you are suspicious that this is lung cancer. But this is something that can catch you out if you're reporting too quickly. When you have lesions that have necrotic luting areas within them and enhancement around them, especially if they present with raised inflammatory markers for some other cause, they can also be reported as infection. The thing to remember, particularly for this one, is that you can't have infective consolidation entering into the mediastinum. So infiltrating of the mediastinal fat is a very sinister sign, and infection doesn't do that. Infection respects the anatomical margins. So a lung area of consolidation, or what you think is consolidation, almost has necrotic looking areas in within it, but is involving the mediastinal fat, has infiltrated the mediastinal fat. In this case, is also inseparable from the arch of the aorta, is highly suggestive of lung cancer. The pleural effusion in this case also would be a malignant pleural effusion. If if this lesion was a small 8 millimeter nodule and this pleural effusion was here, the likelihood of this pleural effusion being malignant would be extremely low. But because you can see that this is infiltrating into the pleura, the visceral pleura is definitely involved. You can more reasonably say that this pleural effusion is actually malignant, and in this case would upstage the staging to one M1A. And this is a purely ground glass lesion. Many ground glass nodules go undiagnosed just because some radiologists don't realize the importance of the spectrum evolving at any point. So this is a ground glass lesion that we would describe with size, slightly spiculated margins, and reported as something suggestive of an adenocarcinoma spectrum lesion. But this is clearly bigger than 8 millimeter. This is a cavitating lesion with significant surrounding thickened soft tissue. When you have a cavitating lesion, they can be post-inflammatory, they can be post-lung infarction, post-lung trauma, post-vasculitis. They can be a very varied number of pathologies that can present with a cavitating lesion. Most of those are post-inflammatory. When you have a isolated lesion, you don't have previous to compare with, or it wasn't there, or it was smaller. Um, with a cavitating lung lesion, what you need to look at is the surrounding soft tissue component or the internal soft tissue component, whichever one they may have. Until recently, cystic lung tumors were not, this is the newer kid on the block, is the pericystic lung tumors or the cystic lung tumors are now increasingly identified as a type of lung lesion. So on the original BTS guidelines, you won't see the mention of cystic nodules or cystic lung lesions, but we now know there are plenty of subsolid lung lesions that actually have a large cystic component or sometimes may only have a cystic component. In that case, what you look at is the soft tissue component, because a cystic lesion, you can't biopsy, you can't PET it to get confident results. You ideally should follow it up if you're worried about the soft tissue. If you are going to action it now, you want significant size in the soft tissue to be able to PET it to get a definitive answer. So in this case, because the soft tissue component is so bulky, it is irregular. If the patient was asymptomatic, has no history of vasculitis, no history of previous infarction, because a small incidental PE wouldn't give you an infarct like that. You see some tethering of the surrounding lung, some architectural distortion. So you would say this is a part cystic, part solid lesion in the left lung. You would measure it. So it'd probably be about bigger than 2.5 centimeter, and you would escalate it to the lung cancer MDT and urgent respiratory referral. Just the same lesion, looking back at it, you can see that this was actually just a small lung cyst that evolved into that. That just shows you that the importance of follow up over time. So and it's very important to put things into perspective when we look back and imagine if you were looking at only that scan, would we have followed it up differently? So in that case, if this was your only scan and you were reporting this scan, you would see the soft tissue component around the cyst is still significant. If this was a simple lung cyst or it was a lung cyst that would not warrant further follow-up, you would want very thin wall, and by thin wall you mean 1 to 2 millimeter. You want a smooth wall. That is what qualifies it as a lung cyst. If you see irregular thickening, irregular mural thickening, or nodularity of the wall, even subtle, it is better to follow that up along a subsolid lung nodule pathway rather than dismiss it. And in this case, you can see it evolving into a significant sized tumor. This, I will put it for you guys in chat and see what your thoughts about this are. Um, what is the morphology and what would you do with this one? Okay, perfect. So the answer I'm looking for is what you guys have all said, that this is the actual description is pericystic tumor. So this is a part cystic, part solid lesion. The solid lesion you would measure, and you would measure the whole lesion. So you would say it's part solid, part cystic, part solid lesion. The solid component measure is, let's say, 8 millimeter. The solid component is slightly irregular. Part of the wall of the cystic component is also slightly irregularly thickened. You wouldn't say I would biopsy it in an exam. You would say you would refer the patient, you would recommend an urgent referral, respiratory referral for consideration of definitive management, including PET CT assessment and consideration of CT guided biopsy, because not many centers, not all centers would offer that a biopsy, because the conservative way of thinking is there is a risk of breaching into the cavity. If you breach into a cystic cavity, a cystic space of a tumor, there is a chance of a bronchopleural fistula. So not all centers take that risk. So the answer, for at least for the exam point of view, is this is a part cystic, part solid lung lesion. The solid component is significant sized. I am worried about this lesion. I would recommend an urgent respiratory referral on a 2-week wait pathway if this was not already done, for consideration of definitive management, progress assessment, consideration of PET CT assessment, as well as biopsy. In some countries, they want to listen the biopsy. I don't understand what that means. If you plan biopsy, would you always PET before biopsy? I mean, would PET always come first? PET comes first in lesions where you um, are planning for surgery because you want to see distant disease. If you have distant unknown disease in a bone or a liver, that changes your definitive management. So the question for PET is, do you do a staging? If you do a chest CT, do you do a staging CT or do you go straight for PET? Most centers go straight for PET because if there was significant disease, it would show up on PET. PET would also possibly show you other sites of disease that may be easier to sample, and they would give you the highest a definitive staging. So if it's a bone met, biopsy proven, and the biopsy shows that it's actually from the lung, you've definitively staged it, and the management changes from that point on. If you have a completely solid or part cystic lesion, you sometimes pet it to find where the highest avidity is, so you can target the biopsy there. In this case, you would biopsy the solid. You're not going to biopsy the cystic bit, so the PET is slightly less important here. This one, slightly unknown entity for non-thoracic radiologists, and you can catch you out, is something called as multifocal adenocarcinoma. You can get multifocal uh, widespread cancer within the lung, and this is primary lung cancer. And this is just along how it spreads. So it can sometimes spread around the air spaces, so it can spread around the interstitium. It goes along the airways, along the interstitium, and actually just spread like an infection rather than a tumor eating through. So it can look like a ground glass classification. It can look like infection. It can look like multifocal infection. It can look like organizing pneumonia. So this one, if you see the left lower lobe is extensively involved with extensive ground glass, even a bit that looks like septal thickening, and you see this foci of ground glass. And somebody reasonably may say that this is, organizing pneumonia or inflammatory etiology. Even in COVID, some might say, but this actually is multifocal adenocarcinoma. This is a very distinct morphology, and these patients present a very certain way. These are usually mucinous adenocarcinomas, the very high component of mucus production. So they present with quite a large proportion of expectorant, and they're very distinct way they present to the respiratory clinicians. These are just adenocarcinoma spectrum lesions that I'm showing you. You can have a spiculated lesion, and you can here see the tethering of the pleura that I told you. This can happen next to a fissure, and this can also happen next to the other side of the chest, so the external pleura. You can have a part ground glass, part solid lesion. You can see sometimes they pull the pleura towards them, sometimes they infiltrate the pleural space and the extra pleural space. And this, sorry, just trying to move this away. And this is what I was telling you before. This is actually a mucinous adenocarcinoma. This involves the whole lobe, acts like an infection, looks like an infection, acts like infection on imaging, not with the patient has ground glass infiltration. They can also be bilateral and extensive, and these patients tend to do quite badly. Part of the reason being that they can go undiagnosed and they don't respond well to treatment either. Something called lipidic predominant adenocarcinoma. Some of you may have heard this term, that's why I put this on. Sometimes it formerly was known as non-mucinous bronchoalveolar or bronchoalveolar adenocarcinoma. carcinoma. So the terminology has slightly changed, and that's why I put that on here. Now the classification terminology is based around the pre-invasive, the minimally invasive, and the invasive. The term bronchoalveolar carcinoma has been retired. It is recommended all invasive carcinomas are classified with the predominant type of histology. This is something that happens at the time of biopsy, or it happens at the post-op sample biopsy stage. So when it is very common for a tumor to have multiple histological patterns. So the pattern that is most predominant is actually put down as the main pattern. It is understandable to diagnose to classify them as non-mucinous or mucinous. The non-mucinous disease is further assessed for patterns like lipidic, acinar, papillary, micropapillary, and solid growth. This is all determined on the histopathological slides and not the radiology. Sometimes a pathologist can say that the sample I got was completely a lipidic type pattern. Does the imaging correlate? And what they mean is, are you looking at almost a fine reticular ground glass sort of pattern on CT? And that's what a lipidic pattern looks like. This is something that grows along the normal structures rather than eat through them. One other thing to remember when I said was a tumor can have multiple predominant cell types. So it's very important at the time of targeting for biopsy to aim for what you think radiologically is the most aggressive part, and that happens to be the most solid part. So if a lesion has ground glass, component and solid component. You always should aim for the solid component, because if you accidentally did or intentionally did biopsy the ground glass, the histological pattern may suggest a minimally invasive pattern, whereas in the center of it you had a more aggressive pattern sitting, and they can change the pattern that way. So just be mindful. This is something to consider for people who undertake lung biopsies. The other lesion to consider within the lungs when you think of tumors is endobronchial tumors. So this is an endobronchial tumor. Endobronchial lesion can be malignant or benign. You can have polyps in the bronchi. What they cause is obstruction, and that's how they present. So an endobronchial lesion, if benign, a polyp, can cause obstruction in expiration, and they can give you either hyperinflation, or outflow obstruction, or they can give you sudden collapse, and that what that causes in secondary infection, and that's how they can present. That nodule can sometimes show up as a small enhancing dot in the bronchus with distal consolidation. If that lesion in the bronchus is actually tumor, it would almost always be a carcinoid tumor. You can also get lung primary tumors, very rare, but it does happen. But for the exam point of view, for a junior edge point of view, the tumor endobronchially that we want you to know about is a carcinoid tumor. These carcinoid tumors are sampled endobronchially by the respiratory physicians, and they have a tendency to bleed, sorry, not breathe. So if you go to lung MDTs, you will notice that the respiratory physician might say, "Oh, I sampled it; it bled a lot. It's a carcinoid, isn't it?" And that's how they can present. Also, they can present with frank hemoptysis, sudden hemoptysis, and that's just based on the cellularity and the composition of these tumors. One thing you will notice on many scans you report is that the trachea is rarely clean. So you have adherent mucus along it, especially in the older population or the unwell population, particularly in patients who've been intubated or extubated, dilated esophagus, a bit of aspiration, a bit of COPD. So it's very common. If you start looking down the trachea, you will notice that there is stuff in it. When to not overcall and when to call. So when you see mucus, when you see something in the trachea, or the right and left main bronchus, is you want to follow and find other lesions that look like it. Other lesions meaning other places you have mucus. Ideally, you should look at the density of it. If it is low density, it is very highly likely to be mucus. And if you see mucus in one place, you're likely to see it in other places along the airway. If it is the isolated finding, is when you will find it disturbing. You want to you think to yourself, is this actually an endobronchial lesion, originating from the wall of the trachea or the right main bronchus or the left main bronchus. The description we sometimes use or suggest is something called dependent or non-dependent. So when you're lying down flat in a scanner, if you do have a bit of mucus, it's going to layer along the dependent portion. So if the same lesion that I'm showing you here was along the posterior margins, somebody would be rightful in dismissing that and calling that as mucus. Because this is hanging from the top, you're slightly more concerned that this is not mucus. The density isn't as low as you would want it for mucus. It's almost the same density as the lymph node next to it. This is at this point, rightfully, you should be concerned. Sometimes you're neither here nor there. You don't want the patient to go through unnecessarily endobronchial sampling. One thing we sometimes do is call the patient back, encourage coughing, aggressive coughing, and then lie down flat for the same scan. And then, if obviously the lesion disappears, it was just adherent mucus. This is just reiterating what I said before. Sometimes you get asked in the exam, very favorite question of some examiners is, what are some of the prime leads that give you endobronchial metastasis? In real life, the most common one you will see is breast cancer, but you can also, the likelihood of being a carcinoid is going to be higher in an isolated endobronchial tumor. This again, this is just to show you how a lesion has evolved. On the previous one, when I showed you a cystic lesion growing, on the first bit, you could see that there was a thin rim that should have been followed up. In this one, this thin cyst, this around it is the vessel. This absolutely should have been dismissed. And this shows you, no matter how correctly you follow guidelines, how accurately you report a scan, if you report enough you will inevitably see that sometimes, no matter how by the book you were, just, things happen, and this did end up being cancer. If at this point somebody turned back and said that cyst was then cancer, wasn't it? Well, maybe, but was the radiologist correct to dismiss it at this point? The answer is yes, absolutely. This is just TNM 8 staging. This came around, I think, the year after the BTS guidelines. This is supposed to be revised, and the TNM 9 is supposed to come out in 2024, I think. But this is what is practiced right now. We don't expect you to know this by heart for the FRCR to be. There is a trend away from memorizing staging for main tumors, but it is helpful to know this at the time of reporting, especially when you are reporting an acute or an on-call scan. You have an incidental finding of lung tumor. The things to remember, most importantly, are the T4 features. And for the purpose of safe reporting, we want you to know um, what to look for central tumors. So SVC obstruction is a life-threatening condition that should be picked up and can be a complication of T4 lung tumor or central lung tumors. So don't be too put off by this. Uh, Again, very easily, you can look it up at the time you're reporting, and it's not an expectation to learn the size criteria. What is important is to know that a satellite nodule in the same lobe is T3, a satellite nodule in the ipsilateral lung is T4. The T4 tumors are the most aggressive tumors. The differentiation with metastatic disease, lung makes it uh, into M1A, B, and C. A is isolated pleural involvement or pericardial involvement. B is isolated extrathoracic single metastatic disease that is still technically curative. And M1C is more than one extrathoracic disease. And what is important to remember is non-regional lymph node. So an axillary lymph node is not an N disease, it is an M disease for lung cancer because it is not a regional node, it is not a node that lung drains into. So that's something worth remembering. Again, something you can very easily look up when you're reporting. Hematoma, I did go through before. This is just to show you that if you had this top one lesion come to you for reporting and you had that calcification, um, but no fat, you can't dismiss it as hematoma, and you should ideally be recommending either a biopsy or at least a specialist referral. This one, you can, with your visible to your naked eye, you can see fat within it. This is absolutely a hematoma. It doesn't need anything else, and you can dismiss it. Again, a hematoma, but because you can't see fat in it, you shouldn't dismiss it. You should, at least for the exam purpose, given the differential of a carcinoid. I think this was a carcinoid from what I remember. This, I think, is one of the last slices, but I just want you guys to tell me what you see on this slice and slide, and if you know the name of this specific appearance. 30 seconds. Yeah, absolutely. This is the reverse S or the golden S when you have a central tumor and you can see the bulge here that is called causing distal collapse. So yes, well done. Central tumor, distal atelectasis caused by the obstruction. This one, I want you guys to tell me whether you think this is a primary lung cancer infiltrating into the bronchus or the other way around, or is there no way of knowing? And what else do you see it on this that tells you that this is metastatic? This is a primary that has metastasized, is what I mean. And I promise we'll stop in a couple of minutes. Exactly. You would expected it to fill the bronchus first before extending outwards. This is indeed a lung mass extending into the bronchus. And somebody said esophageal tumor. Yeah, good differential. Depends on who's teaching you in which session this is. But yes, this is a differential. But if it was esophageal, why you would expect it to radiate from there rather than go along it and extend there. The metastatic involvement I wanted you guys to pick was the pleural involvement and the pleural thickening. So that's M1A disease. Carcinoid is avidly enhancing. Carcinoid is very well defined and very round. And carcinoid doesn't give you pleural involvement like that. So this is a lung primary infiltrating into the bronchus, infiltrating into the pleura, inseparable and likely involving the aorta as well. So that's the summary of today. I hope you guys found it useful. Um, we've taken questions along the way, so I don't think we need to take any. And I think